شنیدید شما؟
بله.
اوکی. دوستان عزیز، با درود و خیر مقدم به تمامی شما عزیزان، سروران گرامی و فرهیختگان اهل علم و تحقیقات. من دکتر محمد شکوه امیری هستم که برنامه اولین کنفرانس علمی سالیانه گروه پاما را به صورت ویرچوال و مجازی برگزار می کنیم. امروز شنبه 13 سپتامبر 2025 ساعت 12 به وقت شرق آمریکا می باشد که برنامه را شروع می کنیم. در ابتدا به خوش آمدگویی از طرف آقای دکتر حسین شکوه امیری، پرزیدنت پاما گوش می دهیم و بعد از آن به خوش آمدگویی از طرف دکتر سعیدی به عنوان وایس پرزیدنت پاما گوش می دهیم. آقای دکتر حسین شکوه امیری بفرمایید.
It's my pleasure to start the first annual meeting of PAMA, which we have the honor of having one of the highest capacity and well-known Iranian scholar that I will introduce him later on, as also he is our honorary member. And we are honored to have him here. And I would like to welcome all the members and the non-members who have interest in our annual meeting. And here we are prepared several scientific papers that will be discussed during the day from 12 to 4 o'clock today. And tomorrow, Dr. Saidi will discuss about it a little bit more, and then again I welcome everybody and we go ahead and start the meeting.
دکتر سعیدی بفرمایید.
Thank you, Dr. Amiri. I would like to welcome everybody to the first annual meeting of Persian American Medical Association. I think this association has been established early in 2022, and with all your participation and help, actually we are able to expand that. Actually tomorrow at the General Assembly, we give you update about the progress that we make in the past couple of years, including membership, our activities. But I would like to thank everybody who participate in this webinar and send their abstract. We have a good mix of abstracts sent to us from a diverse group of people, from junior students, junior faculty, senior faculty. Actually, I'm very proud to announce that we have actually a good group of people going to present their research today. Even the youngest one we have is a 17-year-old high school student actually has worked with us. And then we have a junior faculty and also senior faculty send us the abstracts. And, it was a lot of work put to this, create this and establish this webinar. I want to thank all the leadership at PAMA, and also especially my special thanks to Dr. Muhammad Amiri and Dr. Mateen Muallim Shari, who just, spend a lot of time to create this webinar. I think going to be very interactive and a learning experience for all of us. A few also housekeeping announcement. One, just try to stay on time. I think each presenter, except for the keynote speakers, will have 12 minutes to discuss their work, and then 3 minutes question and answer. I would ask everybody to, mute their voice, that basically we can hear the presenters, and make sure they stay on time. This webinar will provide the 8 hours of CME through International College of Surgeons to PAMA members. If you're not a PAMA member, I encourage you to become a member. Otherwise, with a fee if you want to obtain CME. We also at the end we're going to have 3 youngest investigator awards given to the best young investigator based on their presentation, their quality of their work, and stay on time. And I hope it's going to be a good interactive, experience for all of us. And as I said, because of we provide CME, all these presenters had to talk in English. And again, I welcome all of you and hope that we have a very interactive sessions today and tomorrow.
متشکرم دکتر سعیدی. Thank you very much for your presentation. Dr. Shukwu Amiri, if you would like to please introduce Dr. Ala for the next talk. Thank you.
It is my real honor to introduce to you all the founder of Iranian National Blood Transfusion Service, who has made a history in the medical aspect of Iran's, which I really mean it when I tell you a little bit about the blood transfusion service. Of course, I will not take what he is going to tell, but I will tell you my own experience, why I call him a hero. Before Dr. Ala established the Iranian blood transfusion service, every hospital or every patient who needed blood were at the mercy of the worst mafia system in Iran, that each hospital has a blood bank, and through this blood bank, all the poor people, sick people, addicted people were coming and selling their blood, and we had no other source of blood for our patient, and no blood products were known. Dr. Ala, a very well-trained and well-known hematologist who had his training in England and United States, came back to Iran, and a real patriot and lover of Iran, started to see the problem and establish this Iranian blood transfusion service, which revolutionized the people. I can tell you that I was one of the residents at that time, a very junior person, but we were saying that whenever we needed blood, we were not be able to convince the family to donate blood, and we had to use those dirty bloods. What Dr. Ala did is that made an organization that voluntarily people gave, and it went through a very detailed process to make sure that the bloods are okay, and also started processing the blood and blood products. I was at that time starting a very junior person, while Dr. Ala was very senior, and I'm sure that he does not remember me from that time. But I can tell you that he started the first program in Tehran, and then wanted to have the whole country have access to this fine blood. So the second base was Shiraz. And luckily, I was chosen to be the educator in the blood transfusion system in Shiraz, because Dr. Ala's plan was that people should know, should be educated to donate the blood freely. And I can tell you that we had all the equipment and everything, and we were going to different factories, different government offices and military bases. And when we were going there, everybody was so pessimistic that nobody will donate blood. And after I gave the talk, educational talk, and convinced them that giving blood is nothing bad, but is good for the whole people and for the person himself who's donating blood. And you cannot believe that after finishing my talk, I could see the people standing in the line, rushing to donate blood. And that made me proud to see that a small part of that system that I owe to Dr. Ala, who became my real hero. He is the one who did that one, and that has now turned out to be one of the finest blood transfusion system in Iran. No more any addict or sick or poor people, only donation by the volunteers and healthy people. It's my honor to introduce Dr. Ala to give, who is our honorary member also. We have several very high profile honorary member that we will introduce them one by one. The first one is Dr. Ala. Please, Dr. Ala, start.
Thank you very much. قبل از هر چیز باید تشکر کنم از محبت و مودت استاد دکتر شکوه امیری و همکارانشون که مرا برای شرکت در این جلسه پاما دعوت فرمودن. حقیقتش دو دل بودم از اینکه آیا به انگلیسی صحبت کنم یا به فارسی، ولی خوشبختانه میبینم که مسئله حل شد در واقع. Therefore I propose to speak to you in English about the earliest establishment of diagnostic and clinical management for inherited bleeding disorders like the hemophilias in the Iran of the mid-60s, which is when I definitively returned to live and work in Iran after many years abroad. My first appointment in Iran was as assistant professor Ustad Yar in the Faculty of Medicine at the Tehran University Pahlavi Hospital, known as the 1,000-bed hospital, although there were only 500 in reality. It was a current joke that the number depended upon how many people were in the same bed. My starting salary was the princely salary, the princely sum of 600 tomans per month. And I should remind you that the current price of a non-sangak in Tehran is 50,000 tomans at present. Hematology at the time was an exclusively laboratory discipline dealt with by the Pahlavi Hospital central laboratories. Here, staining of peripheral blood and bone marrow smears provided a morphological diagnosis, and that was it. Modern hematologists are amphibious creatures, at home at the patient's bedside, as well as at the laboratory bench. And I was fortunate in being able to establish the first clinical hematology department, thanks to a grant from the Wellcome Trust for 18,000 pounds sterling, which allowed me to buy all the equipment for a modern hematology lab capable of dealing with hemoglobinopathies like sickle cell disease, thalassemia, hemoglobin D, with leukemias and lymphomas, with inherited and acquired hemolytic anemias, including the equipment for radioisotopic diagnosis, red cell and plasma mass, red cell and platelet lifespan, and so forth. Whilst awaiting the arrival of all this material, I started on hemostatic disorders like hemophilia A and B, as well as the newly described von Willebrand's disease, which was thought to be rare at the time, but which now turns out to being the commonest inherited hemostatic disorder. It was exciting to be able to prove in the laboratory that what the etiology of these various bleeding disorders was. But children suffering from severe hemophilia start bleeding into their weight-bearing joints as soon as they begin to walk. And they usually end up as hopeless cripples from an early age if untreated. At the time, these were truly clinical orphans because no one was interested in dealing with them. Children are dying of measles and diarrhea in Iran, my colleagues used to say. We cannot afford to take on these incurable conditions. Many of these children became drug addicted because of pain and despair. Mothers felt guilty when they discovered they were carriers of the disorder. Sisters were in an agony of doubt as to whether or not they were carriers and would pass the genetic defect onto their sons. The education of affected boys was disrupted, resulting in unemployment and a sense of inadequacy. And not only because of the premature death of potentially useful members of society, but because if left untreated, patients end up as hopeless cripples and a burden upon their families and the health facilities of their countries. But I must first say a few words about the etiology of these bleeding conditions. The mutations giving rise to hemophilia are probably of great antiquity because they occur in at least 3 orders of placental animals: the ungulata, the carnivora, and the primates. Hemophilia has been described in the horse, in 9 breeds of dog, as well as all races of men. Order of which these groups belong may have been distinct from the end of the Cretaceous, say 65 million years ago, and the mutations have probably occurred independently many times in all 3, since it must be lethal in the wild state. The mutation rate has been estimated as between 1 and 4 times 10 to the minus 5. The earliest references to what may have been human hemophilia are attributed to Jewish records of the 2nd century AD. A ruling rabbi, Judah the Patriarch, exempts a woman's 3rd son from circumcision if 2 older brothers had died of bleeding following the operation. It is now well known that Queen Victoria herself was a carrier of hemophilia B, affecting coagulation factor 9 rather than 8 as in hemophilia A. No evidence of the disorder exists among her antecedents, so one must assume that the mutation occurred at spermatogenesis in her father. The Duke of Kent. The disorder only manifested itself for the first time with the birth of her 8th child in 1853, when Leopold, Duke of Albany, was born with hemophilia, which proved fatal when he died of a cerebral hemorrhage at the age of 31 in 1884. Leopold's sisters, Beatrice and Alice, were both carriers. Alice married the Grand Duke of Hesse, and 2 of her daughters, Irene and Alice, had hemophilic sons. Queen Victoria's relentless matchmaking passed the defective gene to another granddaughter, Victoria Eugenie, who married Alfonso XIII of Spain, resulting in both their boys bleeding to death after minor accidents. A further granddaughter, Alex, better known as Alexandra, married Tsar Nicholas II of Russia. And their son, probably the most famous hemophiliac in the world, was Alexei, who was born in 1904. Alexei was also the most tragic case who created so much anguish in the Romanov family. It was through his successful treatment of Alexei's extreme pain by hypnosis when he was 8 years old, probably a psoas muscle hemorrhage, that Rasputin, the charismatic monk, gained such a sinister influence upon the entire household of the Tsar. The last known carrier of Queen Victoria's mutation was Princess Alice, wife of the Earl of Athlone, who represented the British Crown at the celebration in Tehran of Crown Prince Mohammad Reza Pahlavi's marriage to the exquisite Princess Fawziyeh, sister of Malik Farouk of Egypt, in 1941. For lack of any other suitable accommodation, they stayed at my grandfather's house on Couché Berlin, and I wasn't allowed to ring the bell of my bicycle for the entire duration of their stay. Incidentally, Queen Victoria, only daughter of Edward of Kent, who in turn was the son of George III, may also have been a carrier of porphyria, the illness usually attributed to the madness of her grandfather, George III, which causes terrible abdominal pains, skin rashes, purple urine, and mental disturbance. Truly a familial museum of genetic disorders. Inherited deficiency of the 11 or more other blood coagulation factors is relatively rare and often less clinically severe. The one exception is a group of autosomally inherited, mostly dominant bleeding disorders affecting both males and females, called von Willebrand's disease. The most severe form, type 3, resembles severe hemophilia in its intensity and is more common in Iran because of the strong tradition of consanguineous marriage. Thanks to a further research grant, I was able to obtain a large capacity refrigerated centrifuge, which immediately provided the possibility of separating whole blood into components: concentrated red cells, platelets, and plasma. The fresh plasma could be used for treating hemophilic children. However, since polyvinyl blood bags were not available at the time as yet, bottles washed and re-sterilized at the Pasteur Institute were still used. Better still, Dr. Judith Poole's discovery of cryoprecipitate in 1964 allowed for the preparation of a crude, homemade concentrate of factor VIII in the hematology department, using dry ice and alcohol in a bucket, just like making ice cream. Major orthopedic surgery, mainly knee fusion, was successfully carried out in the late 1960s. For cases with severe hemophilia A, it must be emphasized that in the mid-1960s, commercial factor VIII preparations were not easily available anywhere in the world. The sole exception being fraction 1O, pioneered by Birger and Margareta Blombeck at the Karolinska Institute in Stockholm, which was later manufactured on an industrial scale by Kirby. The only other alternatives were bovine or porcine factor VIII produced in the United Kingdom, which were very potent, but dangerously antigenic. One of my cases developed immune thrombocytopenia and a nephrotic syndrome after being treated with bovine factor VIII. A few very brave orthopedic or general surgeons, Dr. Sheikh Islamzadeh, Dr. Gorji, Dr. Kazemi, were actually prepared to take the outrageous risk of operating on our severe hemophilic patients. We had a particularly heartbreaking hemophilic boy of 13 who had been severely crippled since early childhood and had now sustained a fractured leg. He had been immobile in bed for so long that his bones were thinned and porotic, and he required surgery, otherwise he would never walk again. Dr. Sheikh advised that the only way he could be provided with a stable limb was to fuse the knee joint. So an appropriate quantity of our accumulated cryoprecipitate was thawed and infused early on the day of the operation. Dr. Sheikh applied a tourniquet so that he could have a bloodless field. And it was only after the Charnley clamp was fixed to put the knee in extension that the tourniquet was removed, where we would find out whether or not success had been achieved in preventing disastrous postoperative bleeding. Samples of the patient's blood before and after each twice-daily infusion of cryo had to be tested to determine the level of circulating factor VIII, which had to be kept above 50% at all times to prevent bleeding and to foster healing by first attention. This laborious process was continued for 2 anxious weeks, and we were cheered to find that no abnormal swelling, infection, or bleeding had occurred. And this was the first case in Iran for a severe hemophiliac to be operated upon, and it was crowned with success. Many more such operations were carried out with increasing confidence for a variety of disorders: duodenal ulceration, lobectomy of lung for a bleeding hydatid cyst, a first in the world, and hemorrhagic pseudotumor of the pelvis. I should mention that at this point, I left Iran in a rather informal fashion with my knapsack on my back in 1981. And I traveled to the UK, where I became the director of the West Midlands Regional Blood Transfusion Service, serving a population of some 5.2 million. And I also had a clinical appointment as senior lecturer in hematology and consultant hematologist at the Birmingham University Queen Elizabeth Hospital nearby. I only returned to Iran for the first time after some 19 or 20 years for a WHO meeting in Tehran in 1999. By this time, I had retired from the UK National Health Service, but I still wanted to pursue the improvement of hemophilia care in Iran, as I had tried to do nearly 20 years before. The director of the Iranian Hemophilia Society had persuaded the other members of the IHS board, all of whom were either hemophilic themselves or were the parents of children suffering from one or other of the many different inherited bleeding disorders, that the Tehran University Imam Khomeini Hematology Department, which is where I started, as the only center currently offering the diagnosis and care of these patients, had become grossly inadequate for the task. He proposed an alternative solution similar to the one adopted by Alfredo Pavlovsky in Buenos Aires in 1944, and whereas in virtually every country, the local hemophilia society is usually charged with providing social services, publicity, fundraising, printing and distributing information, pamphlets, together with hosting occasional seminars attended by hematology consultants to discuss the latest forms of treatment and the modes of genetic transmission. Diagnosis, treatment, and management, on the other hand, were usually confined to centers in teaching hospitals. Our director of the Hemophilia Society suggested that an independent center for the diagnosis and care of this group of patients, who remained veritable clinical orphans with little access to proper medical attention, should be created by the Hemophilia Society itself, an almost unique model, but for the center established by the Argentinian Hemophilia Foundation. As a result of the inadvertent spread of HIV infection among hemophilic children following the Islamic Revolution, due to the importation and of infected factor concentrates, the Ministry of Health and the National Blood Transfusion Service were taken to court by the Iranian Hemophilia Society, which claimed compensation for patients and families affected by this incurable infection. Governments in most Middle Eastern countries had rarely, if ever, been accountable to their subjects throughout history, and Iran was no exception. It was therefore all the more remarkable that after many years of wrangling and obfuscation, the Ministry of Health finally accepted liability, agreed to suitable compensation, and had determined not only that FDA-licensed virally inactivated coagulation factor concentrates would be imported in the future, but that the vastly expensive plasma fractions imported and utilized in the treatment of these patients would henceforth be administered free of charge, an exceptionally generous policy, which was also extended to imaging, lab diagnosis, and clinical care. Was this spurred by a feeling of guilt? Possibly. The IHS board set to work with great enthusiasm to raise the considerable funds required for creating the first comprehensive hemophilia care center in Iran and to find a suitable location for such a bold venture. Establishing a non-profit, non-governmental treatment center in a country where virtually every agency or initiative was governmental. After much effort and with the support of the Tehran municipality, an ideal centrally located building in a district of the city which was dedicated to curtain material and home furnishing was procured for a song. A former two-story department store in an advanced state of dilapidation, which had been confiscated, musadere, by the owners for unknown reasons by the Shahdari after the revolution. A radical rebuilding plan was set in motion, an additional floor was constructed, handsome pink and white travertin stone was employed for the interior and the facade of the building, an elevator was installed, general and specialist labs were constructed and equipped, including molecular genetics and molecular virology laboratories. An outpatient clinic and consulting rooms were built and furnished, and a two-station dental surgery clinic was created. A physiotherapy department was fully equipped and staffed. All this through charitable donations from companies or individuals. We persistently begged for a DNA sequencing machine from the drug companies and finally acquired an old-fashioned slab sequencer, the Alpha Express 2 made in Sweden, a gift from Kabi, which initiated the very first molecular genetics lab capable of identifying the precise defective family mutation in affected families, female carriers of the pathological gene, as well as prenatal diagnosis through direct DNA sequencing. Several years later, we acquired 2 capillary sequencing machines as donations from companies. Finally, in the few remaining minutes allotted to me, I'm anxious to show you a brief film clip from Dariush Mehjoui's excellent film Daire Mina, which perfectly illustrates the scandalous source of all blood transfusion in Iran before the creation of the Iranian National Blood Transfusion Service in 1974, whether university hospitals, private clinics, Ministry of Health hospitals, and even the armed forces, which coerced soldiers, never officers, to give blood in exchange for 72 hours leave. The Iranian National Blood Transfusion Service only draws blood from voluntary, non-remunerated donors, and some 60% of its donations are from established donors who are the safest because they've been tested many times. I should emphasize that it's not merely a supermarket for blood and blood products, but it is also a scientific establishment which has survived the ups and downs of revolutionary Iran and now is, I think, an intimation of democracy, as people have decided to provide blood for themselves, their neighbors, and their fellow Muslims free of charge and anonymously. Thank you very much. Perhaps we can show the film now. That's no sound. There's no sound.
Oh. Let's see. No, remove pin برای اینکه اگه بخوام فیلم رو نشون بدن بتونن نشون بدن.
صدا چی شد؟
دکتر متین صدا رو هم شیر کنید. صدا رو شیر کنید.
Where is it?
قبل از اینکه کل شیر کنین صدا رو شیر کنیم. Click on the sound.
برین از اول فیلم دوباره لطفاً.
بچه‌ها بیا پایین بینم. یالا چاپیاش بلند شد. بودو بینم. بودو بیا. باریکلا. بیا. باریکلا.
آیا ببخشید آیا فیلم دیده میشه الان؟
بله دیده میشه.
درجه یک. نه خراب شد.
کنار.
باز صدا نداریم. بیا چرا جلوشی؟ واسه بینم. من دیرو نظر کنم بابا ندیدم.
صدایی اصلا وجود نداره.
یالا پاشید بلند شید بریم تو اتاق. بودو بینم. بودو. یالا برو تو اتاق. بودو. بلند شو بینم. بلند شو. برگشتی میگیری ازش. بدش. برو بینم. برو. چیکار می‌خواد؟ بگم بابا نه چه نگته من 2 ساله که ناخوشم ندارم میخوام وایسا چی پیدا کنم به مشمر بگین از من کن دیگه عباس چه مرگشه اومدم بابا اومدم چی نگه بابا من پول ندارم بده اومدی که چیکار کنی اومدی که چیکار من به خیالم یه خبریه گفتین بهت پول میدید نه دیگه به کسی پول نمیدم آی سامری این یه نفری که خودتون پیدا کردیم به درد نمیخوره مریضه اسمش قد بزنید چطور؟ دیگه خون بده من ندارم بیشتر وایسم از کجا خون بده بیا جلو ببینم خودتو داره ماسینت هم بزن بالا زود بش بینم بالاتر بزن بالاتر خیلی خوب باش حسین بجار این شیشهش پر شده یه شیشه دیگه بذار اینجا
با صدا رفت.
حالش به هم خورد خوب شدی بابا باشه برو بیرون علی بابا جون تیز پنهانی زدی در میان سینه‌ام تیر پنهانی زدی باز میپرسی چرا زرد میباشد رنگ تو حال من میدانی و خود را به نادانی زدی بشین بابا کتم دارد بدش کنم خیلی خب حالا بشین چی هستم؟ این خون نداره بابا همین نیم ساعت پیش هر روز داره خون میده 6 جای دیگه میره خون میده نداره بابا مشتری جون اصلا ول کن دیگه
صدا خراب شد. فیلم افسوس.
خب با عرض پوزش اگر کوالیتی صدا و تصویر فیلم ارسال شده به اندازه مورد نظر نبود با عرض معذرت من فکر کنم که به خاطر این کامپتیبیلیتی فیلم قدیمی ایرانی با دستگاه زوم ممکنه باشه ولی ما میتونیم لینک فیلم رو برای تمام دوستان شرکت کننده جداگانه بعد از این برنامه بفرستیم که همه این 8 دقیقه و 30 ثانیه که جناب آقای دکتر علا تلاش کردن برای ما انتخاب کردن بفرستیم در اختیار همه دوستان باشه. با عرض پوزش مجدد به خاطر این کامپتیبیلیتی بین این دوتا سافتور و برنامه با عرض معذرت. جناب آقای دکتر سعیدی دستشون بالا هستش بفرمایید.
ممنون. من اول جا داره که تشکر کنم از مهر بیپایان جناب پروفسور علا که در این جلسه شرکت کردن و واقعا تقدیر کنم از خدماتی که ایشون به علم پزشکی در ایران و ملت ایران ارائه دادن. جا داره یاد کنیم از زنده یادانی که در این نامانی که در این فیلم دیدیم، عزت الله انتظامی، سعید کنگرلو، و یاد کنیم از سازنده این فیلم داریوش مهرجویی که متاسفانه به قتل رسید. این فیلم برای دوستان که آشنا نیستن با این فیلم دایره مینا بود که سال 1353 داریوش مهرجویی درست کرد و 3 سال فیلم ممنوعه بود و به همت دکتر علا واقعا این بساط غیر اخلاقی جمع شد. من متاسفم که بگم که ما یک پدیده جدیدی هم داریم که در اکستنشن این پدیده هست و اون فروش اعضا در ایران هست که اون هم به همین شکلی که الان شما نشون دادین متاسفانه من دیدم میرن و با اتوبوس از شهرستان ها، از محله های فقیر افراد جمع میکنن میارن که اینا اعضاشون رو حالا اهدا کنن، بفروشن، هر چیزی. و واقعا این پدیده به یه شکلی دیگه الان در ایران ادامه داره که امیدواریم که با کمک دوستان بشه جلوی این پدیده رو هم گرفت. ولی دکتر علا، من اینم خواستم بگم، مثل دکتر امیری فراموش کرد، به پاس خدمات شما به ایران و ایرانیان، پاما شما رو به عنوان آنری ممبر خودش انتخاب کرده و ما خوشحالیم که در این جلسه شما رو میبینیم و از تجارب شما و خدمات شما بهره مند میشیم. من خواستم فقط این کامنت رو بگم و تشکر کنم از شما.
خدمت شما که عرض بکنم در ادامه صحبت‌های شما، کاری که پروفسور علا کردن واقعا بی‌نظیر بود و من متاسفم که این فیلم اون قسمت بعدش رو که باید نشون بده نداد. نمیدونم چرا. این قسمت وحشتناک رو نشون داد. بعد اون سیستمی که شما به وجود آوردین و چقدر ارگانایز بود و چقدر خوب اجرا میشد، چقدر عالی. یعنی باید این به ادامه اون فیلم یه چیزی اضافه میشد که مردم ببینن که چی بود و چی شد. اون قسمت من نمیدونم، شاید خود پروفسور علا انقدر واقعا هامبل هستن که نخواستن این در اون برنامه باشه، ولی اون اچیومنت شما هست که در هیستوری پزشکی ایران خواهد بود و در تمام دنیا. حالا اون داستان هیموفیلیا که کانتریبیوشن عظیم شما بوده جای خود، ولی مسئله انتقال خون ایران یک فاجعه ای بود که این فاجعه درست شد و همونطور که دکتر سعیدی گفتن فاجعه به اعظام وجود داره که امیدواریم بعد از سرنگونی حکومت ما بتونیم اینو ترتیبشو بدیم. ما میدونیم اینو. بفرمایید جناب علا. میکروفون دکتر علا بسته است؟
نه خیر، باز اصلا.
نه بازه.
آقای دکتر علا اگر کامنتی در این زمینه داریم بفرمایید.
مرحمت دارید. من فقط اون آخر خواستم بگم که فقط یک سوپرمارکت فراورده های خون و اینها نبود، در واقع یک مؤسسه علمی شد و هنوز هم هست و خیلی امید بخشه. همین حرکت که مردم خودشون داوطلبانه میان و از تمام سطوح خون اهدا میکنند، این نشانه دموکراسی است به نظر من و امید بخشه. هنوز هم ادامه داره و میگم 60% خونهایی که به دست میاد از خون دهندگان مستمر به دست میاد که خیلی در واقع قابل اعتماد هستن. در تمام ایران هم شعبه های مختلفی از سازمان انتقال خون وجود داره. بنابراین it's a national blood transfusion service.
من میتونم اینجا اضافه کنم که خدمت شما که عرض کنم، چون این برنامه در دوران پهلوی با وجود شما انجام شد، مثل بقیه مسائل سعی میکردن که خیلی بیارنش پایین، مثل دانشگاه پهلوی یا دانشگاه آریامر یا بلاد ترانسفیوژن سیستم بیاد پایین. ولی به قدری این مسئله مهم بود برای کل مملکت، مخصوصا زمانی که جنگ شروع شد، نتونستن کاری بکنن و انقدر این برنامه، من این که دارم تکرار میکنم، واقعا I believe in that one، انقدر این مسئله مهم بود که نتونستن کارش کنن. به همین دلیله که داره پیشرفت میکنه. من واقعا سپاسگزارم از جناب علا که این به لطف کردن و همونطور که هممون گفتیم شما عضو افتخاری ما هستین، به ما افتخار دادین، استاد همه ما هستین و ما خیلی خوشحالیم که شما در این برنامه شرکت کردین.
خیلی تشکر میکنم از لطفتون.
با تشکر از جناب آقای دکتر علا، من میتونم قول بدم که اگر بشه کار کنیم که کل فیلم آقای داریوش مهرجویی رو تهیه کنیم و در اختیار تمامی شرکت کنندگان و اعضای انجمن بذاریم که در یک فرصت مناسب بتونن اون رو کامل ببینن که یادی از اون برنامه به اصطلاح اهدای خون و سازمان انتقال خون باشه. با تشکر. اگر از دوستان شنونده کسانی سوالی از جناب آقای دکتر علا در این رابطه دارن میتونن بفرمایید. ما حدود 5 دقیقه تا 10 دقیقه برای سوال جواب فرصت داریم در این زمینه. اگر کسی سوال داره دستشون رو بلند کنن تا من بهشون میکروفون رو بدم. مرسی. خب اگر کسی سوالی نداره ما میتونیم بریم سراغ پرزنتیشن بعدی. آقای دکتر سعیدی بفرمایید در رابطه با پرزنتیشن بعدی. آن میوت کنید خودتونو.
I think our next presenter is Dr. Shuku Amiri. I think Dr. Shuku Amiri doesn't need any introduction. He's a professor of surgery at Louisiana State University, and he's currently president of PAMA, and he will talk about correlation between kidney donor profile index and post-transplant graft survival rates.
Good afternoon, everybody. Again, I start the talk by informing you about the correlation between kidney donor profile index and post-transplant graft survival. Next slide, please. I have no conflict of interest to disclose, and none of the other authors have had any conflict of interest. Next slide, please. Regarding the kidney transplant, you know that transplant is one of the miracles of the 20th century, which also revolutionized the treatment options about the treatments for different diseases. And kidney transplant is one of those, which has a very successful result. And patients who get a chance to have a kidney transplant, they get free from dialysis, which is every other day, all their life, 4 hours per day, and sitting there, coming out of dialysis, tired, and also their lifelong survival is 10 years in average, less than people who get the kidney transplant. But provided that the kidney transplant, if it lasts more than 3 years, is also economically better than going to dialysis, because dialysis costs each time, and when you put together, even though a kidney transplant is expensive, but as a whole it becomes cheaper. But since we believe on, and the organizations of the transplant societies all over the world believe that kidney transplant is better than dialysis, so they try to give it more and more to people. And this is based on the voluntary donation. Since there has not been adequate number of donors to the recipient, then they have tried to use the marginal organs and the CD donors, and it has been shown that the result of the marginal organs is not as good as the brain donor. So that's why we decided to study the long-term effect of marginal donors on graft survival. Next slide, please. There is something called KDPI, which is the Kidney Donor Profile Index. Is a score from 0 to 100 that summarizes the quality of a deceased donor kidney, indicating its expected longevity after a transplant. The higher the score, the worse will be the result. So if somebody has a score of 0 or 20 or 30 or 40, these are ideal kidneys. But when it goes above 85, it means that they are kidneys that they may not work. And if they don't work, the assumed benefit of transplant will not be given to the patient. Next slide, please. These are the things which are involved in calculating this score. Age is considered, weight, height is considered, how long the patient has history of hypertension. If no, or 0 to 5 years, 5 to 10 years, more than 10 years, or if they had, but they don't know how many years they have had a hypertension, or at least unknown. So they are going to be included in calculating this score. History of diabetes. Cause of this, if the patient has died of anoxia, severe stroke or head trauma, or drug or CNS tumor, or others. Serum creatinine, and either if the donor meets the DCD criteria, which is donation after cardiac death, or the brain death criteria. So they put all of them together and make a score between 0 to 100. Next slide, please. The objective of this study was on a large scale, not from a single center, on a large scale, to see the relation between KDPI and post-transplant graft survival. Next slide, please. We use the data, which is United Network of Organ Sharing database for this study, and the kidney transplant, which was performed between 2015 and 2023, were included with 5-year graft survival. Cohort was categorized according to donor type and KDPI. Next slide, please. 119,620 donors were included in this study, which makes from the number of the donors a very valid study. 33.123 or 27.6% had a KDPI of 0 to 20. 17.6% had a KDPI of 21 to 34. 50% had a KDPI of 34 to 85, and only 4.64%, luckily, had a KDPI of 86 to 100. And now we are going to focus on this, the result of this one, to see how are the results. Next slide, please. As you can see here, we are talking about the first year, third year, and 5-year graft survival based on the KDPI. And as you can see, the KDPI and the graft survival are excellent in the first year, which is ideal. And then if we go higher in the KDPI, even the higher KDPI, and in the first year, may they behave properly. And the result is not that statistically different. It's 99% compared to 94%. But as time goes on, especially when we reach to the third year and 5th year, the number decreases and the result will not be good. You can see that a person who has received a good kidney have a very nice survival, and the graft can stay in their body up to 20, 30 years. But the one that has a KDPI of high, they do not live long and they may lose the organ. Next slide, please. Based on this study, we conclude that KDPI has a very significant impact on graft survival at 3 and 5 years than 1 year. And we have to make sure that either they have to put some innovation on high KDPI, like perfusion studies and those type of things to optimize those ones, or we have to discourage the donors that have high KDPI to be donor for the kidneys. Thank you very much for listening to my talk.
Thank you, Dr. Amiri, and thanks for staying on time. Anybody have any question about this presentation? I think I want to start, for audience that are not maybe the new, then if this high KDPI have less survival, I think always we'll ask this question from patients and also our staff, that why offer it to people?
You ask for me? Because they want to increase the number of the transplant, which is ideal. We believe that a transplant, as I said, is a miracle, and the result is excellent in liver, in kidney, in heart, in lung, in all the organs, pancreas transplant. But we have to be careful that even though we want to increase the number, that should be judiciously handled. I think by informing and educating more people for donation, healthier person who donate rather than the sick people. exactly like what Professor Allah was talking about, the donors who were not ideal, and there was a lot of problem. We have to take care of this one also in the organ donation.
Mr. Qavidel, I think your hand is up too.
Ramiri, I enjoyed your talk. The last part I attended. I just want to ask a question. What percentage of these high KDPIs should be considered for dual kidney transplants?
Actually, they are considering those one, but still, when the kidney is bad, the result may be a little bit better. Surgery is more difficult and more time consuming because we are putting 2 kidneys. But also, they have given us the data only from 85% up. It could be, we have asked them more detailed data, for example, 85 to 90, 95, 90 to 95 and above. It may be a little bit different, but at this time, I have only the data from 85% up. But dual kidney may be helpful a little bit.
Thank you. Any other questions from the audience?
دکتر قویدل آیا شما دکتر قویدل
بله
آیا شما
صداتون رو میشنوم.
بله آیا شما سوالتون رو مطرح کردید؟
نه عزیزم، من تو اون لحظه‌ای که فرمودید یه کامنتی راجع به صحبت آقای دکتر علا داده بشه، من از مدیران انجمن هموفیلی ایرانم. و اولا بسیار بهتون تبریک میگم. شما یه سرمایه بزرگو انجمنتون بردید و یک انسانی که علاوه بر این که دانش فراوانی دارن، نقش اساسی در حوزه سلامت تو ایران ایفا کردن. نکته‌ای که من در صحبت‌ها کم بود میخواستم بهش اشاره کنم، دکتر فریدون اعلی موفق شد فرهنگ ترویج اهدای خون رو در ایران جا بندازه. چیزی که انقدر عمیق جا افتاده و انقدر دقیق جا افتاده، یعنی کار شده روش. کسی که این سازمان رو پایه‌گذاری کرد به پایه اجتماعیش، یعنی مردم، فکر کرده بود. شما یه مقایسه ساده بکنید با محیط زیست. سازمان محیط زیست وقتی تأسیس شد تمام بارش رو گذاشتن رو محیطبان، ولی سازمان انتقال خون تمام بارش رو دوش مردم بود و فرهنگ سازی کردن و این باعث شده این سازمان پایدار باشه. یه نکته دیگه هم میخواستم بگم، این که عزیز ما آقای داریوش مهرجویی بعد از اینکه دکتر علا این انقلاب در حوزه اهدای خون به وجود آوردن، اون فیلم رو ساختن. اون فیلم مؤثر در ترویج اهدای خون بود، نه فیلمی بود که به خاطر آن خون فروشی رو تعطیل کردن. خون فروشی رو دکتر فریدون اعلی و همکارانشون با دقیق ترین روش ها جمع کرده بودند. آن فیلم داستان این جمع کردنه. من همیشه ناراحت میشم به عنوان کسی که در حقیقت فریدون اعلی پدر دوم، یعنی پدر معنوی جامعه هموفیلی هم هست، جزو مؤسسین ما هم هست. جوری از فیلم دایره مینا که واقعا یک اثر هنری قابل تقدیر صحبت میشه، انگار اون تقدم داشته بر اقدامات دکتر فریدون اعلی و همکارانشون. من دقیق به شما میگم که اینها اون مؤخر بر اینه. حتی داستان فیلم یک بخشی از شخصیت دکتر فریدون اعلی رو داره. من عذرخواهی میکنم، اون لحظه من اینترنتم قطع شد، نتونستم در لحظه‌ای که اجازه دادید راجع به صحبت‌های دکتر علا صحبت کنم، در حقیقت نتونستم وصل بشم. خیلی متشکرم.
من خیلی متشکرم از شما و همون چیزی هستش که ما بخواستیم واقعا عنوان بکنیم و امیدوارم کرده باشیم به دکتر علا در تاریخ پزشکی ایران قدمی برداشت که ابدی خواهد بود.
دقیقاً من بارها افتخار کردم که ایشون به عنوان یک طبیب، یعنی یک وجه بزرگی از شخصیت دکتر فریدون اعلی طبیب بودنشه. شما باید معاینه های ایشون از بیمار ببینید. بعضی وقتا ما مثال میزنیم به پزشکا، ایشون یه آدم چرکالودی رو که از ته روستاها آمده بود چنان لمس میکرد و چنان ارتباط برقرار میکرد و نهایتا هم حتی پول زیر بالشش میذاشت. از دکتر میپرسیدن پول برای چی میذاری زیر بالش این؟ میگفت این تا آخر عمرش مریضه، باید پول داشته باشه بیاد. من به شما بگم که فدراسیون جهانی هموفیلی هم ایشون رو افتخاراً به عنوان یکی از بزرگترین نیکوکاران و انسان دوستان به جمع خودش پذیرفت و جایزه ویژه‌ای رو به ایشون دادن. من به شما هم واقعا تبریک میگم، برای همتون آرزوی موفقیت میکنم و امیدوارم که ایران عزیزمون هر روز به از نظر دانش علمی فراتر و بزرگتر بشه و مردمش راحتتر زندگی کنن.
بسیار
در
بسیار
سایه صلح، در سایه صلح.
بله، بسیار
عذرخواهی میکنم.
بسیار از کامنت های خوبتون سپاسگزاری میکنم. مرسی.
عذرخواهی میکنم آقای دکتر، به صحبت شما زیاد مربوط نبود. ولی خب حضرت عالی هم
نه خیر، اصلا این خیلی صحبت مهمی بود که ما انتظار داشتیم که کسانی که شرکت میکنن بیان. واقعا این مثل شهادتی بود بر کارهای بی‌نظیر دکتر علا.
بله قربان، سپاسگزارم از فرصتی که به من دادید.
خواهش می‌کنم.
اگر دوستان دیگری در این زمینه پرزنتیشن جناب آقای دکتر علا یا آقای دکتر حسین شکوه‌امیری سوالی کامنتی دارن، میتونن دستشون رو بالا کنن، اعلام کنن تا ما بلندگو و یا دوربین بره طرف ایشون. من سعی میکنم که یه مقداری آرومتر صحبت کنم که فرصت باشه برای دوستانی که میخوان آن میوت کنن خودشون رو و یا دستشون رو ببرن بالا. و یک مسئله دیگر هم میخواستم عنوان کنم در این زمینه، این که بسیاری از نه بسیاری، تعدادی از دوستان هستن که با اسامی خودشون وارد نشدن، بلکه یا به صورت آیفون شماره 1254 هستش و یا سامسونگ شماره 13212 هست که اگر این دوستان اسامی خودشون رو بنویسن خیلی راحت هستش. روی تصویر خودشون بالا سمت راست 3 تا نقطه هستش، روی اون کلیک کنید و بعد میاد چنج نیم هستش که میتونید اسمتون رو عوض کنید، سیو کنید که ما اسامی شما رو ببینیم که چه کسانی در این کنفرانس شرکت کردن، که اگر علاقه‌مند بودید که برای CME کردیت اپلای بکنید ما لیست شما رو داشته باشیم به عنوان وریفیکیشن که به اصطلاح کالج سرجیکال کالج عنوان بشه، مطرح بشه که بتونم به شما CME کردیت رو عطا بکنن و به شما بدن. در نتیجه اسم دقیق شما برای ما بسیار مهم هستش که ما اسم شما رو داشته باشیم. دوستان اگر لطف کنید اسامیتون رو چنج کنید که ما بتونیم ببینیم و یادداشت کنیم. خیلی متشکرم.
بریم سر سخنران بعدی.
آقای دکتر سعیدی بفرمایید.
آقای دکتر نزاکتگو هستن؟
بله.
بله دکتر نزاکتگو هستن. بله آماده.
Okay, our next presenter is Dr. Nezakatgou. Dr. Nezakatgou is senior surgeon and senior transplant surgeon at the University of Tennessee at Memphis, and he's going to talk about single center experience with portal and technique in pancreas transplantation.
Good afternoon, everyone, and thank you for the opportunity that the PAMA has provided for me to present our experience with pancreas transplantation. I was just wondering, should I handle this or how this works? I don't understand.
Dr. Nezakatgou, you just tell us next slide and then we will change the slide for you.
Next slide. Briefly, I will touch about history of pancreas transplantation. That's a big history, but we just need to be very brief because of shortage of time. I will define different pancreas transplant categories and review outcomes briefly and review our centers, and in the end, it will be our conclusion. Next. I have no financial disclosure for this speech. Next. The first pancreas transplant officially and successfully performed in 1966 in University of Minnesota in Minneapolis. That is considered one of the probably mecca of pancreas transplantation, the way that Pittsburgh is considered mecca of liver transplantation, founded by Dr. late Dr. Starzo. Dr. Kelly and Lilehi did the first pancreas transplantation, and if you see in this picture, there was no duodenal jump graft in this successful pancreas transplant, and there was a jump venous graft that was hooked to the iliac vein. And actually, 3 months later, this vein got thrombosed and patient got pulmonary embolism and also sepsis and died. The first patient was 28 years of age, but patient had low blood sugar and pancreas was working. Next. First successful pancreas transplant, kidney pancreas, was in December 17 of 1966, but it was published in 1967. Next. Immediate outcome, patient died of sepsis and also pulmonary embolism. Next. This is David Sutherland, who definitely is the father of successful practice of pancreas transplantation in the United States and in the world. And for the first time, he did the first living-related pancreas transplantation with half of the pancreas in 1979. And first islet cell transplant, again, was done by him in 1974. Next. Currently, these are two methods of pancreas transplantation. One is for drainage of the exocrine function, that is either to bladder, or majority are doing enteric drainage. This is for exocrine. I should mention that the pancreas is an organ that only 1 or 2% of that is islets, and the rest is for exocrine function. But we cannot do islet transplant in everyone, and results are not as good as solid organ transplantation. Next. And this is what we are doing at our center. This is pancreas with a piece of C-loop of the duodenum hooked up to proximal jejunum. And this is the SMV that is hooked up to the pancreas with the portal vein. This is the technique that I will explain, was founded by our dear friend and honor of our medical association, Dr. Hossein Amiri, who was my mentor. I had the privilege to be trained by Dr. Amiri in Memphis, and later on, after 6 years in 2006, he moved to Shreveport, Louisiana, and they were lucky to have him until last year. Next. A background of pancreas transplant is definitive treatment for selected insulin-dependent diabetic patients. Choice of exocrine drainage is either portal enteric versus systemic enteric. Systemic enteric, as I mentioned, was introduced in 1966. And the technique that we are performing, and we are very happy with that, is founded and initiated by Dr. Amiri for the first time in 1990. And he presented the first 5 cases in Lyon in France. And the official literature report of that was in 1992 in Transplantation Proceeding. Portal enteric technique developed at UT Bolt Hospital, University of Tennessee Transplant Center, taken over by Methodist Transplant Institute in 2004. Dr. Amiri worked another 2 years in Methodist and then left our center, and now he is in Shreveport, Louisiana as Director of Research Program. Next. Portal enteric technique provides physiological advantage over systemic drainage, and this presentation offers comprehensive long-term data from the intermediate volume center like ours using portal enteric method. Next. These are papers that you can look at later, written by Dr. Amiri initially, these two particularly. Next. And the first comparison of the systemic and versus enteric, again, was done in Memphis, Tennessee by Dr. Estrada. And at that time, I had started my second fellowship, and this was one of the landmark articles. Next. As you see, Dr. Shukru Amiri, Dr. Robert Estrada, they were main part of pancreas transplantation in all the studies in Memphis, Tennessee. Next. Since we have shortage of time, I don't want to go through the current pancreas transplant in worldwide and in the United States, but these are available for the audience to read later. Next. Currently, more than 38,000 pancreas transplant has been done in United States. In the past 3 years, it has been between 850 up to 930. And overall, 88% of kidney pancreas transplant are SPK, that is simultaneous pancreas kidney transplant, 6% pancreas after kidney, and 6% pancreas transplant alone for those patients with hypoglycemic unawareness. That is one of the most important indications for pancreas transplant in type 1 diabetic patients. Next. If you notice in this bar graph, you are seeing that up to 2010, they were doing up to 1,500 pancreas transplant yearly, but now it is around 850 to 900, and this is a declining trend that it has its own explanation, but it is not topic of speech, and you look at it in other slides. Next. These are also the difference between type 1 and type 2 diabetic patients. In the past, only 2% of patients with type 2 diabetic patients were candidate. Now more than 20% of the pancreas transplant is done in the type 2 diabetic. And surprisingly, if about 50% of type 2 diabetic patients are African American. Next. This is the pancreas transplant technique. I don't want to go through all of these. We don't have time. Next, please. Next. Next. Only 25% of patients worldwide are getting transplanted by portal enteric technique. In the United States, this is about 15%, because this technique introduced 25 years later. Next. I don't want to go through the details of the technique, but I will briefly show the pictures. Next. Next. This is the midline incision. We create a pouch on the left side. Next. Next. This is the pouch. Next. This is the vessels, and we put the kidney first. Next. Next. These are the jump grafts. Next. 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 Next slide. This is the SMV that is exposed. Next. 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 This is the SMB. This is the portal vein anastomosis SMB. Next. Next. And this is the anastomosis performed with portal. Next. This is after completion of the anastomosis wire graft. Next. And next, this is the first layer, and this is the completion of the anastomosis. Next. I will, since we have shortage of time, I will just briefly let you know that in this group that we had 185 patients, 61% were male, 39% were female. Next. Only 7 per patient were done by systemic enteric and 178 by portal enteric. Next. 159 were simultaneous, kidney pancreas, 20 pancreas after kidney, and 6 pancreas transplant alone. Next. Our thrombosis rate was 2.6% compared to the national average that is 6 to 8%. And in the past 8 years, we have had consecutive 64 patients with no graft thrombosis, that is essentially 0%. Next. Next, this is a meta-analysis that is showing 6.1% portal enteric group, 8.5% in systemic group graft thrombosis. Next. 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 Vascular thrombosis happened in 4% overall, but in that first group that is about 121 patients up to 2017 from 2004, 4%, but in the next 64, it was 0. I have 4 more slides to finish the talk. Next. Portal enteric technique demonstrated significantly lower thrombosis incidence compared to published national data, reporting 8% thrombosis for systemic enteric for 6% for portal enteric. The Memphis Center's outcome surpassed these national benchmarks, supporting the portal enteric technique, reproducibility, and safety. Next. Consistency of portal enteric usage, especially in recent years, under a single experienced surgeon, reinforces the method's robustness. Next. Methodist University Hospital, 21-year experience, affirms the portal enteric technique as a superior and evolving method for pancreas transplantation. This approach significantly reduces vascular thrombosis rates compared to national averages, contributing to improved graft survival. Continued perpetuation of this tradition, coupled with surgical expertise, establishes the portal enteric technique as a best practice standard in pancreas transplantation. Of course, I had this, but they have put my first, version. My next, edited version was different than this. But overall, I can say this is a better practice. Thank you for your attention, and this is our team in Methodist University Hospital. Thanks.
دوستان عزیز، اگر کسی سوالی در رابطه با سخنرانی دکتر نزاکتگو دارن بفرمایید. Dr. Saidi, you have a question?
Thank you, Dr. Nezaket, for excellent presentation. I want to ask you, what are you guys doing? You think is different that the rest of the country? That's why you achieved such a good result with such a low graft thrombosis rates.
I think that honestly, I can put only 3 reasons for that. One is maybe being a little lucky. 2 is we use heparin after transplant for 3 days, and that is important. But with low dose, 300 units per hour, first day, 400 units second day, and also 500 units third day. And also, I believe that paying attention to details of surgery is very important. And for the past 8 years, I have been the only surgeon to do this, the pancreas anastomosis. Of course, I give with fellows, with other partners, but I'm thinking that just perpetuation and being loyal to something that you have learned it well, you have been trained with, is important. My partners tried; they were trained in Mayo Clinic and also in Minneapolis, Minnesota. They wanted to go back to systemic enteric, but Dr. Eason, who was our program director over here, he said that I was trained in Harvard, in Mass U, and they were doing all systemic, but I learned to do portal enteric, and I think it is a better technique. So I modified it, and now I'm very proud to present this, results. Uh, I learned it from Dr. Amiri, and I'm really thinking that this technique is superior. And if you do it right, it is easier because it is more superficial, the anastomosis, and also it is safe. We have had zero thrombosis of portal vein that some people are very afraid of. They have shown that this is the first pass, so it is more physiologic because portal vein drains directly through the liver. This is the first pass. And also they have shown that incidence of rejection in both groups, systemic enteric and portal enteric, is equal statistically, but the severity of rejection is a little less in portal enteric because liver plays some modulatory effect immunologically to have less severe rejection. Overall, we are planning to completely review all of the cases that we have done in the past 20 years with detail of the outcome and present this and publish this. And definitely I will send this to you and Dr. Ramiri for your expert, editing and help me to publish this in one of the good transplant journals, maybe in next 2 or 3 months.
Thank you, Dr. Nazakatgoo. Dr. Amiri, do you have any comments or questions? Please unmute. Please unmute.
We have evolved our technique. Now we do not use portoenteric. We do portogastric. We connect it to the stomach, and the literature is there. We started in 2007 when I moved to Louisiana, and since then we are doing portogastric, which is easier to access the pancreas through endoscopy and also biopsy taking, which does not need to do percutaneously or ultrasound guided. It makes it easier. So that we have evolved that one, and hopefully that will get better. And also the future is robotic. We are going to start. A few centers have started to do robotic surgery, so that long incision will disappear, and robotically we put both kidney and the pancreas in the body.
Thank you very much. Any other questions from Dr. Nazakatgoo? I have a question, Dr. Nazakatgoo. Regarding the thrombosis of 2.6%, this is a very excellent result. However, I'm wondering about other complications and survivability of your patients. Do you have any report or result on other complications and also the quality of life of your patient after 3 years or after 5 years? Do you have any comments on that?
Actually, clearly I can say that infection rate in our patients have been much less than before, and reported things in the literature. Usually most centers do the pancreas first and then do the follow with the kidney transplant, and the time of exposure of wound for contaminated bowel is a little longer. And there are something about 25 to 30% infection rate and sometimes wound complication in pancreas transplant. In our cases, this is about 10%. And the reason is I'm doing the kidney first. When I'm doing the kidney, I do this with my partners. I create the pouch. My partner is doing the kidney, and I'm doing the back table of the benching the pancreas, and then we put the pancreas in. This adds only 1 hour for the procedure, but the time of the duration of exposure for dirty material, not dirty, we are just intestinal content is a little shorter, and then we close the abdomen. This is one thing. Another thing is we are hooking the C loop of the duodenum to the proximal jejunum just 20 centimeter after ligament of Treitz. Here we have much less contamination compared to the systemic enteric that by necessity it is hooked up to terminal ileum that is very highly colonized with more innocuous bacteria. That is probably the reason. But we are going to write this up, and then you will have hopefully the result that is close to national average regarding 5-year survival of graft and long-term follow-up of our patients.
Thank you very much. Dr. Atena Farkhonde has questions, please.
Yeah, thank you. Thanks, Dr. Nezakatgoo. I have a question in general. What type of patient do you normally consider for the pancreatic transplants? Do you consider cancer pancreatic patients as well to do the transplant as well, or?
Any kind of pancreatic cancer is contraindication for pancreas transplantation. It is different from, for example, malignancy of the liver, that HCC, you can remove the liver and put, a new liver for transplant. Pancreas is not like that. Even pancreas tumors like neuroendocrine tumors, so far, I don't believe that it is a standard of the care for pancreas transplantation. Primary indication for pancreas transplant are type 1 diabetic patients, and preferably those with hypoglycemic unawareness. But there are some group of patients with type 2 diabetic patients that now they're about 20% of pancreas transplant patients overall. They are candidate, and they are those patients that they are mimicking and behaving like type 1 diabetics. They have burned out pancreases. At the same time, they have lower resistance for pancreas because they have lost a lot of weight, and their BMI are ideally is under 27. These are two groups that are candidates for pancreas transplant, but no cancer patient with pancreas tumor or malignancy is a candidate for pancreas transplant.
Thank you so much. I appreciate it.
Sure, thank you.
Thank you very much. If there are no more questions or comments, we can move forward to the next presentation by Dr. Daniel Zamanian. Dr. Saidi, بفرمایید.
Yeah, our next presenter is Dr. Zamanian, who's going to talk about code blue-green inclusions of doom.
Hello, are you able to hear me?
Yes.
Well, thank you for the opportunity and invitation. So basically, the research I'm presenting is called Code Blue-Green Inclusions of Doom. Inclusions of Doom is basically a nickname given to these findings on peripheral blood smear, which is green neutrophilic inclusion bodies. They call them the death crystals. And they are associated with critical illness and high mortality. There are not many literatures out there which explain these findings. Next slide, please. They are associated with poor prognosis. They did a 2018 review, which showed 56% mortality within 2 weeks. And they usually appear in very ill patients, usually in the ICU setting. Next slide, please. Initially, they thought that these inclusion bodies were a byproduct of liver injury. But the more research they did later on, they were able to figure out that these are not necessarily secondary to hepatic injury. They are consistent of lysosomal degradation products, but till this day, they don't know exactly how they are made. They don't know the full pathophysiology of their creation. Next slide, please. They are rich in lipids. They have possibly some association with lipofuscin. And we've done liver biopsies, and it's shown some lipofuscin deposition, which is suggestive of phagocytosis of lipofuscin after severe tissue injury. Next slide, please. So they're rare, usually in the ICU setting of our hospital in Louisiana. The laboratory people told me that this finding occurs maybe 3 or 4 times on a yearly basis. And almost all the patients are in the ICU setting, as I mentioned. Next slide, please. So we did a case series where we basically reviewed 3 patients who were admitted in the ICU setting. The first patient was a 50-year-old male, history of diabetes, ESRD, who had a kidney pancreas transplant in 2023, CAD status post-PCI. Next slide, please. This patient had some post-transplant complications, had a delayed graft function, required hemodialysis. Basically had a rectal abscess with fistula and ano with multi-drug resistant organisms, and was being treated with multiple antibiotics, had a wound vac in place. Wound cultures were growing several species. Also turned out to have CMV and BK viremia. So very ill patient in the ICU setting. Next slide, please. The patient's clinically was getting deteriorated. He was having worsening mental status, and basically had to get intubated for airway protection. At that time, the CBC, we didn't order a specific peripheral blood smear, but the lab technician was aware of these findings and gave us a call and reported these green cytoplasmic inclusions that were found in the patient. And basically this patient, his condition rapidly deteriorated, and he had a cardiac arrest and unfortunately passed away. Next slide, please. The second case was a 79-year-old female, had numerous past medical histories such as diabetes, CAD, and a recent non-STEMI, which required a PCI. Came to the hospital with nausea and confusion. The patient had undergone dialysis, and the confusion had gotten worse afterwards. Came to the ER, and in the ER, the patient was in sinus tachycardia, had cardiomegaly on chest X-ray, and workup showed an elevated white blood cell count, which was concerning for sepsis. So was started on broad spectrum antibiotics. Next slide, please. The patient eventually deteriorated, became hypotensive, bradycardic, was noticed to have seizure-like activity, got transferred to the ICU, had to be on vasopressors, did a bedside echo, which showed an ejection fraction of 10 to 15%. Basically had to broaden antibiotic coverage, and numerous blood transfusions had to be given. Patient had to go under urgent hemodialysis because of hyperkalemia and acidosis. Next slide, please. And eventually the patient had a progressive decline and underwent cardiac arrest and eventually passed away, but the blue-green neutrophilic inclusions were noted again hours before her passing away. Next slide, please. The third case is an 87-year-old male. Again, numerous past medical histories, came with shortness of breath, edema, nausea, vomiting. On arrival, he was AFib RVR with an ejection fraction of 40 to 45%. Patient did have a history of being on amiodarone and Eliquis with regards to his AFib history. Next slide, please. And they are, as mentioned, he was an AFib. He seemed to be in a CHF exacerbation-like picture, and had to be initiated on cardizem, but then became bradycardic and hypotensive. Did a bedside ultrasound. Patient had some mild gallbladder wall thickening and ascites. In addition to that, workup showed AKI and abnormal liver function panels, and he eventually underwent cardioversion with return to sinus rhythm. Next slide, please. However, there were some complications afterwards. The patient became short of breath again, hyperkalemic. His AKI persisted. At this point, we believed it was ATN, probably secondary to hyperperfusion. He did have some sepsis-like picture. They initially thought it was a possible amiodarone reaction, but eventually the patient required intubation, was transferred to the ICU. Pressors had to be initiated. Next slide, please. And eventually, unfortunately, the patient developed multi-organ failure and a possible ischemic bowel, was transitioned to comfort care. And right before his passing away, we found blue-green crystal inclusions. So basically, these blue-green neutrophilic inclusions, they are rare findings, but they have been found in patients before they pass away. And the literature, as mentioned, is not very, you won't see much literature on these green neutrophilic inclusion bodies. Next slide, please. This is a picture of the peripheral blood smear showing a segmented neutrophil with green cytoplasmic inclusions or crystals of death. They show a reactive, they are surrounded by, we are seeing also normocytic red blood cells surrounding the neutrophils in this picture. I wish I had a flash to pinpoint the green inclusion bodies, but if you pay attention, you might be able to find it. Next slide, please. So basically, these green neutrophilic inclusion bodies are found in multi-organ failure, sepsis, acute hepatic failure, and basically appear shortly before a patient passes away. Next slide, please. So basically, as mentioned, we still don't know exactly how these crystals are made. We have some theories. We know that biliverdin might have some association to it. There might be some relation to systemic inflammation and cellular damage, and possibly some association with the aging process of the cells. Next slide, please. Now, in all of our three cases, we did have multi-organ failure. So there seems to be an association with multi-organ failure, whether it's the kidney, the liver, heart. So there is an association there. Next slide, please. So, in the clinical world, we do have some markers which are, for instance, used for inflammation, such as ESR and CRP. The question that arises is could this finding be used as a prognostic marker for death? And if so, could we figure out how what the exact pathophysiology of making these crystals are? And if so, could we reverse it? And that's a question that humankind has had throughout history, which is immortality. Could we achieve it based on maybe these crystals? Next slide, please. So for future, we still need to do more research on figuring out the mechanism of how these crystals are made. And it could be potentially used as a valuable prognostic tool in the ICU setting, especially in patients with multi-organ failure. Next slide. Thank you.
Thank you, Dr. Zamanian. If there are any questions, it seems that Dr. Sanatkar has his hands on. بفرمایید دکتر سناتکار. دکتر سناتکار، شما صداتون رو نداریم. We don't have your voice. Unmute, please. Until Dr. Sanatkar fixes microphone, I can ask a question so Dr. Sanatkar can come and after me. Dr. Zaman, thank you very much for your great presentation. I have a question. Do you have any pathology autopsy report on your patients? Because they died, and then I'm quite sure that they did also autopsy. Do you have any clear report from the autopsy report what other findings they find and registered beside the green-blue inclusion in the neutrophils?
Well, thank you for that question. No, unfortunately, there is no autopsy report on the patients, but that's a very, very good idea, and I think that's very good for the future to, obtain autopsy and a pathology report.
Yes, because I'm a pathologist and I do some hospital autopsy, so this could be very helpful to figure out what happened in other organs, because you mentioned multi-organ failure, so it is very important if we can find also inflammation in other organs and also to see if there are the same findings in those neutrophils.
Absolutely.
I think Dr. Saidi forgot to mention that we have award for the young investigators. So please go ahead, Dr. Saidi, explain. So now the older generation, except Dr. Zamanian, rest of them are a younger generation. They need to know that there is such an award. Go ahead, please.
Yeah, as I mentioned during my remarks, we're going to have 3 Young Investigator Awards given, and these awards are given based on your presentation, how original your presentation is, your methodology, ability to present, keep on time, and ability to answer questions. I think this is something that we keep track on, and after the meeting, we will announce who will receive these awards. These are cash awards.
Thank you. Dr. Sanatkar, are you ready?
Can you guys hear me?
Yes.
Oh,
Go ahead,
great.
please.
Thanks. What a great presentation, Dr. Zamani, and I enjoyed it very much. So I understand that it's very difficult to deal with neutrophils because of them being dynamic, and by the time also taking samples will be very hard because they lose their structure easier. Dr. Shukamiri can confirm. But since this has been really interestingly correlated with poor outcome, I think there should be a design of a study so that we can probably take samples and from the tissues right away, and then whether we can do maybe IHC to take a better look at them, but also I can think of the transcriptomics studies that may lead us to some clues how the pathophysiology behind these neutrophils are. And then, because I think based on what we see here, by the time that we see them, it's too late to do anything for them. So that's just a little comment on that.
Thank you very much for the feedback. Absolutely, that's something that I think is actually necessary. I'm open to doing that research because I think we need to figure out more. And what an excellent idea! I totally agree. Thank you for bringing that up.
Thank you, Dr. Sanatkar. Dr. Amir, do you have any comment?
No. I just I have to bring down my hand.
Okay, very good. Yes, and thank you very much, Dr. Zamanian, for a great presentation and cases. And Dr. Saidi, are you going to the next presentation?
Our next presenter is the Dr. Ehsani, who's going to talk about tumor targeting TLR9 agonist promotes anti-tumor immune activity in intracranial glioma model.
Okay, good afternoon, everyone. My name is Amir Zassani. I'm a general surgery resident at Willis Knight in Shreveport, Louisiana. This is a preclinical study on enhancing TLR9, toll-like receptor 9 agonist efficacy. I have no disclosure or conflict of interest. To give you a little bit of background about this type of tumor, this is GBM, the most aggressive primary brain tumor with poor prognosis, and the current treatment for that is going to be surgery, chemotherapy, and radiation. Immunotherapy is a kind of new addition to this category, but we're facing challenges like blood-brain barrier, trafficking of the drug, and also the tumor immunosuppression characteristics against the immune response of the human body. Also, we're thinking about toll-like receptor 9 agonists, which is a kind of recognition pattern to activate dendritic cells, T cells, and NK cells, and reversing the immune suppression. Next, please. The study rationale is to create an agent called PEP-CpG. But what is PEP-CpG? This is a kind of CpG component. It's a synthetic agent containing CpG motifs that can activate toll-like receptor 9 on specific cells like dendritic cells and B cells to stimulate both innate and adaptive immune system. So we need to be specific in terms of delivery, and then we created this peptide immune targeting kind of component to add it on our CpG model and improve the selective delivery. The hypothesis is that this PEP-CpG will go to the tumor microenvironment and activate the tumor cells, kind of the immune response against the tumor cells, and remodel the tumor microenvironment. Next. We also thought about a combination strategy, which is focusing on a kind of mechanism that the tumor is using against human body, which is the programmed cell death. So what it is that PD-1 is like a programmed death. When it binds to the PD-L1, it causes death for the cell. And in GBM, it uses kind of its own advantage. And we wanted to tackle that by creating antibody, which we call anti-PD-1. It inhibits this T cell activation. It causes T cell exhaustion, and then again, by creating this anti-PD-1, it inhibits that exhaustion and it works against the tumor. Next, please. So by blocking this inhibitory signal, by using that anti-PD-1, by restoring the T cell function, reversing the exhaustion, kind of working on the proliferation and activation of the T cells, and enhancing the anti-tumor activity, that is what will be achieved with this combination of strategy. Next. So the study method. This is an animal model, like a GL261 cell line that is going to shine where you're using your imaging and injecting luciferin. Our arms were 4. So we had control, we had anti-PD-1 antibody group, we had PEP-CpG, we had combination therapy. And we administered the like different agents through the peritoneum on day 10, 12, and 14 after tumor implantation. Then we assessed the survival of the mice, and we kind of did the immune profiling by flow cytometry. Next. The results showed significant improvement of survival when you use monotherapy of the PEP-CpG alone, and even better kind of survival when you use combination therapy. Next. And the reason for that was justified by infiltration of CD8 positive T cells by dendritic cells, that they were significantly higher in combination group comparing to like anti-PD-1, PEP-CpG, or even the control group. Next. Root cause of that kind of infiltration is upregulation of CD69 and 86 kind of activation markers and co-stimulatory molecules. And it eventually increased the dendritic cell response, NK cells, B cells, and myeloid cells in the tumor microenvironment. Next. So to conclude this study, it proves that PEP-CpG can significantly increase the survival of mice comparing to the control group. And when you combine it with anti-PD-1, it it has even a better kind of efficacy. It changes the tumor microenvironment and kind of remodels it by turning it from a cold microenvironment to a hot microenvironment, because it recruits a lot of immune system subsets like different cells, NK cells, dendritic cells, and it supports advancing this PEP-CBG towards clinical trials and investigating like new drug studies and phase 1 clinical trials because of a promising targeted immunotherapeutic approach for GBM, and to overcome these key limitations of current treatment modalities. Next, these are my references, and I would be happy to answer any questions. Thank you so much.
Thank you very much, Dr. Ehsani. That was a great presentation about the topic. If there are any questions or comments from the audience.
Yeah, I have a question. I think nice presentation. I have two questions actually. One is this human glioma cell line, or this is from different species?
Yeah, so GL261 is specific for mice. So this is a preclinical. We just use the GBM model in mice.
But the cells that you inject, are they coming from human glioma?
No, so when you're injecting the cell for mice, it should be specific for the mice. It's kind of compatible with the GBM model that affects human, but it acts specifically on mice. If you inject it to human, it's not going to affect the human because
And the
of
mice
safety
model
protocols.
that you use, is this immunocompromised mice?
No, the mice are not knocked out or not immunocompromised like these are like the native mice.
Yeah, I think that the main criticism of this kind of model is that they don't behave like human glioma. How you deal with that challenge?
So the situation is there are a lot of, this is like an R1 grant project. So there are a lot of prior episodes of different research to show that this model acts kind of significantly equal to human GBM. There were a lot of like investigational studies. And then after that, this is a kind of eventual study at the end of it to finalize the grant.
I see. Thank you.
Sure.
Dr. Ehsani, how long does it take to inject and develop GBM in mice? How long does it take from
Correct.
the time of injection to the fully development of GBM?
Thank you for that question. So usually depends on the cell line. The GL261 is a kind of fast growing cell line. It usually takes about 7 days for the tumor to kind of develop. And on day 14, we do a lot of imaging to kind of check the tumor size and everything, but 7 days for development of the tumor.
Thank you.
And I must miss this. You injected in sub-Q? Already injected?
So every single injection was done intraperitoneally.
Intraperitoneal.
Dr. Amiri?
Wonderful research. I'm so happy to hear that. What's the next step?
So the next step, like we worked on this GL261 cell line, but the current literature is kind of focusing on all different cell lines. So you have to show it at least on 2 different cell lines. So we can try with a different GBM model cell line that should be luciferin positive and try to show the same kind of results. And we're working on that. And then to finalize the grant, the multi cell line kind of a study will be published soon, about next year.
Thank you, Dr. Ehsani. If there are no more questions or comments, Dr. Saidi, we can go over to the next one.
Yeah, our next presenter is Dr. Siavash Safi, research fellow at SUNY Upstate Medical University, and he's going to talk about evaluating outcome of preemptive kidney transplant in patient over 65 using high KDPI kidneys compared to the non-preemptive recipients.
Good afternoon, everyone. My name is Siabash Safi, and I'm pleased to present our work titled Evaluating Outcomes of Preemptive Kidney Transplant in Patients over 65 using high KDPI kidneys compared to non-preemptive recipients. This work was done in collaboration with my colleague, Dr. Mahmoud Reza Moin, and under the supervision of my professor, Dr. Reza Saidi. I have no conflict of interest to disclose. Next slide, please. To begin with some background, chronic kidney disease is a major health issue worldwide, and once it progresses to end-stage kidney disease, the treatment options are either dialysis or kidney transplantation. Preemptive transplantation, meaning before dialysis begins, has been shown to provide better survival and quality of life compared to starting with dialysis. However, in the United States, only about 2.5% of patients actually receive a preemptive transplant. The shortage of donor kidneys is one of the biggest barriers. The Kidney Profile Index, or KDPI, is a scoring system that measures the quality of a donor kidney with values over 85% considered high KDPI and typically associated with worse outcomes. These kidneys are often allocated to older patients. Next slide, please. Prior research suggests that some high KDPI kidneys are underutilized, even though in certain situations, they may provide meaningful benefits that motivated our study focusing on patients over 65. Next slide, please. With that background in mind, let me walk you through how we designed our study. For this study, we conducted a retrospective analysis using a scientific registry of transplant recipients, SRTR, from January 2000 to May 2023. We included patients older than 65 years who received deceased donor kidney transplant, excluding those with prior transplant or missing KDPI data. The Kidney Donor Profile Index, KDPI, was used to measure donor kidney quality, where a score above 85% indicate higher risk organs. We compared 4 groups based on KDPI, low versus high, and transplant type, preemptive versus non-preemptive. Survival analysis was performed using Kaplan-Meier curves with log-rank test, and use multivariable Cox regression to adjust for relevant donor and recipient factors, including age, BMI, education, sex, race, history of DM, number of mismatches in HLA A, B, and D R-loci, peak PRA, cold ischemia time, DMN as the cause of kidney failure, induction therapy, and donor history of smoking. Next slide, please. Now let us look at our findings. We included over 47,000 patients older than 65 years with a median age of 69 years and a median follow-up of 3 years. Patients were divided into 4 groups based on KDPI and transplant type. The Kaplan-Meier analysis shows clear differences in graft survival. The low KDPI preemptive group achieved the best 3-year graft survival at 95.4%, while the high KDPI non-preemptive group had the worst at 85.4%. For patient survival, the best outcomes were again in the low KDPI preemptive group, followed closely by high KDPI preemptive group. Suggestion that preemptive transplantation confers a survival advantage even when using a higher KDPI kidneys. These differences were all statistically significant by log-rank test. As you can see in this slide, left picture present the graft survival with low KDPI preemptive had the best chance, and also in the patient survival. Next slide, please. We then performed a multivariable Cox regression, adjusting for relevant donor and recipient factors. This chart shows the multivariable Cox regression results, again with the low KDPI preemptive group as the reference. For graft survival, the green bars, the high KDPI non-preemptive group had the worst outcomes with a hazard ratio of about 2.9. Next came the dark blue bars, the high KDPI preemptive group with a hazard ratio of about 1.9. And finally, the cyan bars, the low KDPI non-preemptive group with a hazard ratio of about 1.5. But in the right side of the chart, when we look at patient survival, the trend shifts. Once again, the green group had the highest risk, but now it was followed by the cyan group, and then the dark blue group performed better with the lowest risk among the non-reference categories. The difference highlights a key point. High KTBI preemptive transplantation offers a survival advantage for patients, even though a graft survival is less favorable compared to low KTBI non-preemptive transplantation. Next slide, please. In summary, our findings suggest that utilizing high KTBI kidneys may still be a viable option in older recipients, as long-term patient survival was comparable to that of low KTBI kidneys. Importantly, preemptive kidney transplantation was consistently associated with improved outcomes, even in high KDPI cases. This highlights the critical role of transplant timing in optimizing outcomes for older patients. Final slide, please. Thank you for your attention. I especially want to acknowledge my colleague, Dr. Mahmoud Reza Moeen, and my professor, Dr. Reza Saidi, for the valuable contribution, along with the rest of our research team. Thank you very much.
Thank you very much, Dr. Safi. That was a great presentation. If there are any questions or comments from the audience, please go ahead.
I think my hand is up.
Yes, please go ahead.
Okay, it was a very good presentation, but can you speculate why the result is acceptable in older patients with high KDPI?
Traditionally, the high KDPI kidneys are offered to older patients because the results of prior studies showed that it has not a very good quality. But as long as this is a very long queue for the transplantation, they are offered to older patients. So we focus on these study groups, this population, to evaluate the outcomes.
But I think the real reason is that, as I showed earlier, it may function the high KDPI for a few years, and the lifespan of the older people are shorter. So the patient may die with functioning graft. If they give it to a younger patient that may survive 10, 15 years, it will not be good. So I think it's a wise way of using high KDPI in older patients, because as long as they survive, they do not need to go to dialysis. So that's, I think, the main reason for being good for the older people.
That's completely right.
Do we have any more questions or comment to Dr. Safi? If not, we can go to the next presentation. Dr. Saidi?
Yeah, our next presenter is Dr. Amir Sanadkar. Dr. Sanadkar did this work while he was a research fellow at Mass General Hospital working on xenotransplantation, and he's currently surgery resident at NYU, and he's going to talk about modulating human neutrophil rolling in porcine endothelium, effect of silo adhesion and GBIB blockade combined with genetic engineering under microvascular flow.
All right, thank you very much, Dr. Saidi. Thanks, everyone. This is a great gathering. I think I was feeling very excited, although not the best timing during the intern year, but somehow I found managed the time to be presenting two works, one today, and I promise tomorrow's work will be even more exciting than today. So as you can see the title, to break it down a little bit, I have been working on the roles of neutrophils in order to basically working on xeno field. We were trying to optimize the PICs and the medications in a way that we have better survival and make this type of transplantation safe and available for everyone. And next slide, please. No disclosure, just to share, as Dr. Saidi said, this is the result of the work that I did at MGH, and doesn't have to do anything with what I am doing now and by you necessarily. So briefly, for those who are not in the field, I think this is very transplant heavy gathering, which is really good. But Xeno, why Xeno? Of course, we know that more than 800,000 Americans are suffering from ESRD now, and then the organ shortage has been very tough. There have been people are pushing the envelope on every aspect by adding the DCD organs and doing the even accepting the marginal organs. But still, we are far away from, as you can see, we did just 28,000 kidney transplants in 2024, and it's incompatible to the total number of the people who need the organs. And of course, the mortality associated with dialysis is nowhere near what we expect or would want our beloved patients and people to be suffering from. But in terms of the Xeno, so here comes donors that you can have as many as you want, and that's the best thing to solve the issue if we can deal with its own issues. So basically what have been done in Xeno, been trying to optimize pigs' organs and their genetics in a way that we can have them inside the human body or the other species in a way that it's not rejected first, and secondly, it's functioning properly. So it started with understanding that we get to have the organs rejected right away with it few minutes and few decades ago, and they figured out that there are genes or carbohydrates on pig organs that needs to be out. As you can see here, removal of these antigens, which we call GAL antigens, did increase the survival from seconds and minutes to hours and days, which was done primarily by David Cooper. But as the time went on, we found more and more antigens, but also we understood that like it's really good to add human genes inside them so that they can work against the higher thrombophily situation that after xenotransplantation happens. I don't want to go to details, but this is just for your reference here. Next slide, please. So yes, if we think that we can solve this issue, that these organs become compatible, at least increase the survival to a meaningful way, then we don't need to really go far and look for the organs. We just take the organs that is proper in size and then get it transplanted. Next, please. So I had the privilege of working on mostly thoracic organ xenotransplantation back at MGH, heart and lungs. And during the past 2-3 years that I did like 60, 70 lung perfusions or xenoperfusions, which we perfused pig organs from different genetics with fresh human blood. This was very common finding that we used to see very early on, despite all those genetic additions that I talked about. And we then learned that pigs are just simply very much prone to ischemic reperfusion injury. And that adds to all these situations and problems that we had. Next slide, please. This isn't from another experiment that we had, but this was not even with the human blood. It was just an esteem solution confirming that pigs are prone to ischemic reperfusion injury. Next, please. So going back to the pathophysiology, there have been various ways that we have understood that how ischemic reperfusion can and lead to primary graft dysfunction. But one of the very classic ways have been that neutrophils are not doing good. Neutrophils should just pass by through the vessels and not get stuck to the endothelium, not damaging the endothelium, and not getting into tissue in an exaggerated way. So I was thinking that maybe they have a role. I asked around from the mentors. They said, we've not really studied that. So I thought maybe there's something to work on. Next, please. So I had a very cool device in the lab. No one was using it. I said, why not? Let's use it. This is bioflux setting, which is a micro vascular type of device that you can have vessels that you can put endothelial cells in, and then perfuse them with whatever perfusate you want. In my case, it will be for sure human blood and pig endothelium. And on the left-hand side, you see the generator. It pushes the perfusate, or blood in my case, over the endothelium in a shear controlled and temperature controlled way. And then you can see there's a microscope. This is a nice fancy microscope here that I could take as many as photos I wanted, and then make a video and see how the blood cells do in my case, neutrophils, when they roll over the endothelium. Next slide, please. And next, please. So this is the plate I had and I was using in most of the experiments for this project. Next, please. How it was working is that you can see outlet and inlet cells. I used to proliferate, going back, during procurement sessions from pigs, I used to take a chunk of the aorta and then isolate the endothelial cells, proliferate them, put them in the input well, push them into the channel. The bar on the lower side you see is the channel, and then let them grow and proliferate and become confluent. Next slide, please. This is again the story of the pathophysiology. I don't want to go through details, but there are different receptors and mechanisms that we think makes neutrophils interested in the endothelium, which is absolutely what we don't want early after on in transplantation. Next, please. So the method I had designed was to coat these channels with monolayers of endothelial cells, PAC are porcine aortic endothelial cells, and then make them angry with TNF, and then draw fresh blood, and then either treat it or not, and perfuse it over the channel and see what happens. Next. So this is the proliferation phase, which took me 1 to 7 days. Next. And then coating with the help of fibronectin that helps the cells to attach. Next. And then this is how my channels would look like a day before the actual perfusion. Next, please. So on the perfusion day, when I see the channel are coated, ready to be perfused, I took the blood, stained it with calcine, which is a fluorescence antibody and attaches to leukocytes and platelets. And then after 30 minutes, I can perfuse that blood over the channel. Next, please. So what I designed was 60 minutes of human blood perfusion over 5-dyne, 37 degree. I took 181 images from each channel and made a video. Next, please. So this is a flow of a sample of one of the channels. The fluorescent objects are either leukocytes or neutrophil, or platelets. Next, please. It should pop up a video. It does not. This is very sad. So, yeah, exactly. Play it, please. Cannot. Okay. Maybe one more time. Cannot play media. It says it. Very sad. Okay, no worries. Next. So what I did was, okay, we know these are, how do we know they are neutrophils? So I used another software and then narrowed down whatever the objects that we see in the channels based on their size and circularity, as you can see, and ruled out whatever were platelets or other leukocytes and just looked at the neutrophils alone. Next. And this is how it looks. The bright objects are now neutrophils. I could find neutrophils rolling over the endothelium. Next, please. This is not a video. So it's interesting because on each channel, I could see more than 1,000 neutrophils. And then based on the size and circularity, I could use the ImageJ software and find each neutrophil, meaning that each neutrophil gets an ID, unique ID. And then I looked for their mean speed. Going back to the pathophysiology, if neutrophils stop and then decrease their speed or decelerate, that's a bad phenomenon. That's probably the start of ischemia perfusion. Next, please. These are, again, 2 videos, cool videos from different genetics to show you how the speed of neutrophils is completely different. I hope we can play these videos. Martin, can we see if it works? Unavailable. That's so sad. I wish I could play it on my side. So we can do it. The upside video is a just gal knockout, simpler genetic. The lower was a more complex genetics.
Excuse me, Dr. Sanskar, because
Sure.
these are very important video. Matijan, can you give the control to him so he can play his? Do you have the presentation?
I should have
ready?
the slide in hand. Yes.
Yeah, if you have it ready, so we can give it to you.
Sure, I can.
Thank you.
Then I go for the share.
Yes.
Thanks so much.
I stopped the sharing.
Okay. Lovely.
Okay.
Share.
So,
And then my screen. So do you see my screen now?
yes, we can see that.
Lovely. Going.
You can also go to the first movie, what's that video?
Yeah, this is the first video.
Yes.
And this is like, you see, some objects are moving so fast. Some of them are just rolling around. Many of them are just leukocytes, but the faster ones are usually neutrophils. So going back to where we were here, this is just a very simple gal knockout pig endothelium being perfused with human blood. This one is a more complex gene, which we are using now in clinical trials. You can see the speed, very different. Barely see the cells get stuck to endothelium, while we used to see here that many of them are just on the screen and not moving, passing by.
So you mean that neutrophils migrating faster than?
So this is not a migration. This is just neutrophils don't get stuck to endothelium if the genetic is better, like human genetic. But if the simpler genetic, like wild type pig, they get stuck to endothelium, and that's the starter process of migration and ischemia reperfusion afterwards.
Thank you very much.
So we can go back to Martin if we can, please.
Oh, you should stop sharing, and Dr. Shukramiri should allow me to request to share my screen.
Okay. But I think that would be, yeah, stop share. Okay, I stopped that. Lovely. Okay, next, please. So every neutrophil I got an ID for. Every line you see here is a different neutrophil. And on upper left-hand side, you can see wild type pig, and you see neutrophils are just crazily moving around. Right on the right lower hand side, you see a 10 GE pig that was the first clinical trial that MGH used for a kidney. You see less of them. But interestingly, you see huge clot, and it happens very much with them. And that necessitates the question for me that the genetic alone is nowhere near what we expect to see or proper enough. Next, please. Same thing here. You see genetics gets better, but you see clots. But on the wild type, which is the upper left one, you see just cells crazily moving around. Next, please. And again, different genetics, different situation. Next, please. And then mean speed, I told you, I think, at least based on the pathophysiology, speed matters a lot. And I was so happy seeing that difference. So I moved forward and also tested medications. Next, please. So I used two medications in my experimental design. One of them was the antibody 1F1 or sialyl adhesion monoclonal antibody. This is again one of the molecules or proteins we've seen on the porcine endothelium and we think should be blocked for the transplantation. And the second one is anti-GP1B, which is the molecule that blocks the connection between platelets and von Willebrand factor on the endothelial side. So try to avoid and decrease that clots that I saw previously. And then I used the same experiments many times with different genetics, with different medications. Next, please. So don't want to make you bored. Different groups of experiments that I had from different genetics based on the treatment plus minus of each. You can see far left hand, wild type with no treatment. Far right hand side, I used human cornea endothelium cells as the control here and basically saw how other groups do. You can see all groups I at least have 3 replicates so that I would be able to publish later. Next, please. Next, please. These are without treatments. Again, you see a nice shift as we modify the genetics better. They get better in terms of the speed of the neutrophils. Next. This is the monoclonal antibody I used. There is correlation that it gets better, but when you see, for example, 10GE, 10GE alone is even better than a simple gene modified with treatment. Next. And same story for the antiplatelet treatment that I used. Next. Here we go. I tried to not to go into details. Thank you very much, everybody. This is like a big list of the people that supported me during this time. And the upper right side is my wife and daughter. Thank you very much for your attention. Happy to answer any question.
Thank you very much, Dr. Sanatkar, for a great presentation. If there are any questions or comment to Dr. Sanatkar, please go ahead and raise your hands.
I can expect more questions tomorrow.
But that was very interesting today as well.
I think,
Dr. Saidi, you have a
yeah.
question?
Yeah, I think that in in this field of xenotransplant, it's always a question that what's the right genetic modification, and you think is this 10 genetic editing is good enough, or you suggest based on your study that we have to have more genetic modification?
No, in our in vivo or large animal transplant models, we think that there's a lot of room for improvement for the genetics, and actually the now 3 kidney recipients, xenokidney recipients at MGH did not receive these type of genetics. They got organs from another company, which is eGenesis. That's a Cambridge-based company, which have like 60, 70 genes edited. And most of them, although are porcine retrovirus knocked out, but the goal is to make the pigs better so then we use less immunosuppression.
Any more questions or comments? If not, so I can inform the group that we are done with the first session of the afternoon conference, and we have another session after a break. We are very good with time. We are almost 15 minutes before time. Thank you very much to all presenters who finished in good time. And so we can have a break, 15 minutes break, and then after 15 minutes we resume the next session. So in that way we might be able to finish the conference 15 minutes earlier than expected and planned. With thanks to all presenters and audience, we are going to have a 15 minutes break. Thank you very much.
Thank you.
خب با سلام مجدد به تمام عزیزان شرکت کننده. ما میتینگ رو سر ساعت 2:45 2 دقیقه دیگه شروع میکنیم و صبر میکنیم تا تمام عزیزانی که برای بریک رفتن برگردن. و اگر اسپیکر بعدی آقای دکتر دین عبدهو آماده هستن، خودشونو استند بای نگه دارن برای 2 دقیقه دیگه. دکتر متین شما آماده هستید؟
بله.
مرسی.
دکتر سعیدی.
دکتر سعیدی هم آماده هستن فکر کنم.
من آماده‌ام.
مرسی. 1 دقیقه دیگه شروع میکنیم. دکتر سعیدی بفرمایید.
Okay, welcome to the second portion of day one of PAMA's annual meeting. I think our presenter is Dr. Dean Abdehu, who's going to talk about the correlation between BMI and long-term outcome in liver transplant recipients.
All right, thank you very much. So my presentation is the correlation between BMI and long-term outcomes in liver transplant recipients. I just want to thank Dr. Amiri and Dr. Zabari for guiding me through this research, and everyone here to allowing me to present today. So we can continue now. So no financial or non-financial disclosures. So this research is mainly due to the fact that we know that obesity rates are rising dramatically in the United States. This trend extends to liver transplant recipients, creating new clinical challenges. So we wanted to look a little bit deeper and to see if BMI should be a reason why someone should be held from getting a liver transplant. While BMI's influence on general transplant outcomes is documented, there isn't a specific role as to what the outcomes of patients with large BMIs have. So we can go to the next slide. So if you look at this result from Statista, looking from 1999 to 2018, you see that BMI is slowly increasing. So the average BMI in 1999-2000 was around 29.9, and we see the trend increasing to, in 2018, it's now 42. So this is not just liver transplant patients, this is in general US adults with obesity, but this also bleeds into patients who are getting liver transplants as well. Next slide, please. So the study aim is to evaluate the effects of BMI on liver transplant outcomes, specifically looking at 1-year graft survival of patients at different BMI categories and seeing their 1-year graft survival rate. So why this matters? This may influence patient selection criteria. It also helps refine peri and post-transplant management, and it provides evidence to guide decision-making, whether that be whether a patient should have a liver transplant or not. Next slide, please. So this is looking at the methods of the study. The study design was a retrospective cohort study. We used the UNOS database, looking over a span of 10 years from 2014 to 2023 with a 1-year follow-up. We looked at different donor types, looking at deceased and living donors, and we separated these donors into different BMI categories. Using a chi-square test, we looked at different characteristics and outcomes. Next slide, please. So this is our patient distribution. We looked at nearly 70,000 patients. It was 69,968 to be exact. And we, using the UNOS database, we divided each of these patient populations based on their BMI, with a BMI of 25 to 29 being the largest group we looked at. And we looked at patients with a BMI greater than 40, was about 4.4% of the patients studied, was our smallest group. Next slide, please. So looking at some of the results that we saw, like I discussed, we were looking at 1-year graft survival rate, and we saw that there really overall there was no statistical significant graft survival difference across different BMI groups. The deceased donor had a p-value of 0.25, and the living donor was a p-value of 0.22. So this tells us that there was no statistical significant difference in graft survival rate within the first year of liver transplantation. Next slide, please. So to conclude what we discovered, BMI category does not affect first graft year survival after liver transplantation. Then this is consistent across both donor types. So whether we were looking at the deceased or liver donor recipients. What we gather from this is that BMI alone should not be considered a barrier for liver transplantation. We do know that having a patient with a larger BMI causes perioperative complications. It has its difficulties with surgery, with more difficult techniques needed to take care of the patient. Also, the amount of time that the patient has to be in surgery also increases the amount of anesthesia that they're exposed to. But looking just at BMI and 1-year graft survival rate, there was no statistical significance. What we can say is in the future, we would like to look at more categories of patients with BMIs, with more categories. For example, looking at BMIs from 45 to 50 or 55 to 60 to see if these patients would not, if they also have no statistical difference as well. We also want to look at graft survival rate in 5 to 10 years, not just 1 year as well. So there's future studies that need to be done, but at this time we know that there's no statistical significance in 1-year graft survival rate. So can move on to the next slide. Okay, that's my presentation. Thank you.
Thank you, Dr. Abdehud. Thank you for a great presentation. If there are any questions or comments from the audience, please go ahead and raise your hand.
Yeah, my hand is up. Nice presentation, but I have a couple of questions. One, why you just use 1-year graft survival? Why you didn't go beyond that 5-year, 10-year? Because those data is also available.
Well, that's a good question. That is something we do want to look at, but we just wanted to look at, first of all, the 1-year graft survival rate, because some patients get turned down just for having too large of a BMI. So this is why we did the 1-year graft survival rate. But in the future, we do want to look at more.
Yeah,
larger.
I think if in future, if you want to do this, do some literature search, because I think our group beat you guys. We published this a couple months ago in World Journal of Surgery.
Okay. We'll look into it.
Yeah, I think we published this, look at the obesity and liver transplant, and we'll just, we have 5-year data, 10-year data, and, again, was no significant change. But one thing we found out that there are significant improvement in survival, in especially the last 10 years for obesity patient, because now NASH is #1 cause of, etiology require liver transplant. We see more and more obese patients, and these patients coming up. And it seems that, in the past 10 years, we have done significant progress. This is not just surgical technique. I would say also, selection is better, post-operative care is better, and that's why we achieved this data.
Okay, that's great. I'll look into that.
Yeah, look into that.
Dr. Amiri, you have a question?
Yes, I have to help Dr. Abdo to answer this question. The time that he sent the abstract, we asked from the UNOS, and initially they gave us 1-year graft survival. So he sent the abstract, and now we have received up to 5 years. Still, they have not given more than that, but that's part continuation of his study project, and he is going to look to all of those. We have correlated not only with BMI, also KDPI, with the liver transplantation. All of it we have included, so he will continue his project. This was the initial part that UNOS did not give. They are very reluctant. You have to ask specifically for everything that you want. You have to ask so they can give it to you. Otherwise, he would have done that one. And also the anesthesia care has improved. ICU care has improved. A lot of things has improved that the result is better. But they need much more intensive care after transplant. To mobilize a patient with BMI of 55 or 60 is needs time and personnel. They may get infection in the wound, so they have some more comorbidity, but they can benefit. Now, these days, we advocate that when they are morbidly obese, at the same time, we do obesity surgery for them also. So when we do obesity surgery, so hopefully not only we have removed their bad liver, we do not let them to become obese again. Hopefully they can lose weight more.
Thank you very much. Do we have any more questions or comments to Dr. Abdahu? If not, we can go to the next presentation. Dr. Saidi?
Yeah, our next presenter is Dr. Maliha Muhammadpour, who's going to talk about primary CNS lymphoma, current management, and future landscape of treatment. Is Dr. Muhammadpour here?
Was she here before?
I think so.
Okay, so maybe she's
Go to the next presenter.
maybe she's extending her 15-minute pause. Let's go to the next presenter, and then she will present. Who is the next?
Okay, our next presenter is Dr. Atena Farkhonde.
Farkhonde, Dr. Farkhonde, Atena Farkhonde.
And she's going to talk about induced pluripotent stem cell for neurological disease drug recovery.
Yeah, thank you so much for the exciting and informative conference today, and thanks to Dr. Shukouhi for the invitation. My name is Atana Farkhonde Kalad, and I'm a Therapeutic Development Manager and a Staff Scientist at National Center for Advancing Translational Science in CATS, NIH-HHS. And because most of the project we manage are involving intellectual property and IPs, so I decided to talk about one of the review papers I published about induced pluripotent stem cells for neural drug discovery today. So hopefully it would be exciting. And if you need more information, you can always reach out to the published paper. Next slide, please. So disclaimer, any views expressed in this presentation are personal and do not represent the official views of NIH or the US government. Next slide, please. So patient-derived induced pluripotent stem cells are very useful models for neural drug discoveries. So as you know, neurological diseases such as Alzheimer and Parkinson are growing problems as average life expectancy are increasing globally, and drug discovery for neurological diseases remain a major challenge. One of the reasons is poor understanding of the disease pathophysiology and incomplete representation of human disease in animal models. That one hinders the therapeutic development. Recent advances in induced pluripotent stem cells have enabled us modeling human disease with patient-derived neuronal cells. And these iPSC models utilize drug screening and compound screening and drug development. Right-hand side, you would see a schematic picture of somatic cells turning to iPSCs, neuroprogenital cells, and they can be used for different neuronal models, and assay development process, compound screening, and finally, lead and new drug and clinical trials. And next slide, please. So translational studies that you may heard recent years and drug discovery. So drug discovery is mainly three phases: a discovery phase, which involves all this assay development and iPSC usage. And then the lead can be moved to the preclinical development process, which involves efficacy pharmacokinetic studies, drug substance, and product manufacturing, toxicity and safety evaluation. And once everything is gathered, we will file the regulatory affairs, such as FDA. We will file IND, pre-IND, NDA, etc. And then clinical trial will start. So translation process starts with the basic science research, and then which involves preclinical and animal studies. And then we go to T1 is a translation to human, and that's the proof of concept phase 1 clinical trial. We go to patient in T2 is phase 2 and phase 3. And then we go to translation to practices, which is phase 4 clinical trials and clinical outcome research. And then it's the translation of new data to clinical and health decision making. And finally, it goes to community, and that's where we see the true benefits to our society and the patients. Next slide, please. So here is just a figure of showing an overview, very brief overview of how induced pluripotent stem cells have been developed throughout the years. First study was in 1962, where they transferred this nucleus from somatic cells to the egg cells, and they made the first frog. And then there were advances such as making dolly sheep, as you may all remember, and then embryonic stem cells. And in 2006, Takahashi and Yamanaka, through the 4 famous factors, they were able to make stem cells from the somatic cells, such as fibroblasts, hair follicles, or even urine cells. And that was a very evolutionary, and they got the Nobel Prize for that. And that those cells can be the baseline of generating so many different models and not just in neuronal cells, but in so many different areas. And in this case, organoids, brain organoids, or embryonic models, and so on. Next slide, please. Here it just shows a couple of models that can be generated through iPSCs. iPSC can be induced and differentiate to neuronal progenitor cells on the top left, and they can be differentiated to neurons or astrocytes. And these cells can be used to model as monoculture or co-culture systems. We can use them for organ and chip development, and use our drugs or potential drugs to evaluate the phenotypes recovery. They can be transplanted to in vivo systems, not mice, not even mice, any other in vivo system. They can be used to make embryonic bodies or brain organoids, and they can be transplanted to our in vivo systems and to study the function and the connectivities in different areas of the brain. They can make brain assemblies. Next slide, please. So the highlights would be neuronal diseases and neuropsychiatric diseases are growing global problems. Effective therapies for neurological diseases are still unmet medical needs, and animal models do not often accurately represent human neurological diseases. And induced pluripotent stem cells, or iPSCs, are very good models for human disease modelings. Next slide, please. So main neural iPSC models are consistent of neural stem cells, neural progenitor cells, and neurons, co-culture, and organoid and mini brains. That on the right-hand side, you would see the immunofluorescence pictures of iPSC, NPCs, and neurons, and right down, you would see the brain organoids formed from week 0, week 1, and we can culture them up to 15 mouse, and they are very valuable model for studying different diseases and the drug discovery process. Next slide, please. iPSC has been used for so many disease modeling, such as Alzheimer's disease, Parkinson, ALS, Huntington, epilepsy, schizophrenia, bipolar disorder, autism, depression and anxiety disorder, rare genetic disorders, and so many more. And for the interest of time, I'm just talking about a couple of them here. Next slide, please. So modeling Alzheimer's disease with iPSC-derived brain cells. Alzheimer's disease is a highly prevalent neurodegenerative disease involving with progressive loss of neurons in the brain. And as you know, the majority of patients suffer from sporadic AD, and 0.5% are familial ADs. And the reason for the development of SAD are widely unknown, but some study suggestions are spontaneous germline mutation in some genes such as ApoE and so on, that they are mentioned in the table here. And the major cause of FAD are mutations in PS1, PS2, or APP genes. And on the right-hand side, you would see that the cells from the Alzheimer's disease patient somatic cells can be differentiated to iPSCs, and these iPSC, they can be differentiated to different neuron cells, and we can study and use them for the drug discovery development and see how the phenotypes of these different mutations can be recovered. And those medications that we have in the market, most of them are the achievements from these developments. Next slide, please. Another disease is Parkinson's disease. As everyone knows, it's the second most common age-dependent complex neurodegenerative disease, and it's characterized by the loss of dopaminergic neurons, dopamine neurons, and they are extensively modeled by iPSCs. To this date, 17 genes with the PD causing mutations have been identified throughout this process, and many of them has been used for generation of dopaminergic neurons in patients' iPSCs. And interestingly, many of these disease phenotypes, such as increased apoptosis, reduced neurites, impaired autophagy, mitochondrial deficiency, and oxidative stress, they are all confirmed in familial and sporadic PD patients, iPSC neurons. So it shows how powerful these models can be, and they have been used. Next slide, please. Another disease that has been used is the ALS. ALS disease with iPSC models. So as you know, ALS is a devastating neurodegenerative disease, and it's a progressive loss of motor neurons. And there are no very effective treatments, at least at the time, and several iPSC models have recently been reported from these patients, and they have been used to differentiate to motor neurons, and about 90% of ALS patients with the sporadic disease, they have been differentiated to neurons, and so many genes involved with these has been identified, and so many clinical trials designed based on those. So many disease phenotypes, such as the ones that is indicated in the table, you would see they came from the iPSC characterizations by these patients. Next slide, please. Another disease is Huntington disease that has been modeled with iPSC, and is another inherited neurodegenerative disease, primarily affecting GABAergic neurons. And around the world, about 5 to 10 out of 100K are involved with Huntington disease, and increased cell death, sensitivity to a stressor, glutamate toxicity, and reduced sporadic electric firing in the neurons have been all reported in the HD patient drive iPSCs. And you would see that they have been used for the drug screening, and sometimes gene editing and corrections and transplanting again to patients. Next slide, please. So here are different other diseases that have been modeled that I indicated in the paper, and because of the interest of the time, I could not go through all of them, but this shows that the power of these iPSC models for drug discovery, for our understanding about the mechanistic underlying each disease that helps us move to where all of our physicians involved in treating the patients. Next slide, please. And so as a concluding remarks and future perspective, neural and neuropsychiatric disease affect large population globally with improvement in healthcare. Humans no longer succumb to historic causes of health, such as infectious diseases, accidents, and so on. Although the improvement in lifespan is welcome, but ensuring the higher proportions of neural disorder is a challenge. Therefore, it's an unmet need for relevant models of pathophysiology for neurological diseases. Major limitations in current neurological research and drug discovery includes the lack of valid disease models and unavailability of disease-specific human neural cells. Therefore, iPSC technologies offer new opportunities to model human neurological diseases using disease-relevant patient cells. And here we presented how actual patients can be used to provide tissues leading to development of iPSCs, which are biologically relevant to assays, and finally to drugs and addressing the needs for the patients. Although the methods for iPSC generated has been well established, the disease-relevant cell models are still in a process of more optimization and development, and we believe that drug discovery for neurological diseases will advance more quickly in parallel to the development of iPSC technologies. Next slide, please. So I would like to thank our team, and this work was supported by the Intramural Research Program at TDB NCATS at NIH. And with that, I would be happy if there are any questions, and I hope it was informative for the group here.
Thank you very much, Dr. Farkhonde, for a great presentation. That was a very, very interesting topic. And if there are any questions or comments to Dr. Farkhonde, please raise your hands. Dr. Saidi, please.
Thank you, Dr. Farkhonde. I think this was very actually timely topic that you talk about. This is a very innovative technology that became available. I want to just mention that the person who actually developed this technology to be able to convert somatic cells to stem cells was Professor Kamanaka, who used to be a Japanese transplant surgeon. And in 2012, he received Nobel Prize for this. And that's basically has bring a lot of hope for patients with genetic diseases or other type of diseases that you mentioned, for example, neurological diseases. There's a lot of, for example, hope for patients with diabetes. They can be able to convert their own cells to islet cells and cure their diabetes. Recently we were at this World Transplant Congress in San Francisco, and they present a couple patients that were a couple years out, treated their diabetes with this technology. But some, there was always concern about that with this genetic modification you have to make a stem cell, there's a room potentially for teratoma. Do you want to comment on that?
Yeah, so for that reason, when the iPSC is generated, there are a couple of standard tests that needs to be done because they need to go through several passages, like up to 20 or even 50 passages. And throughout that time, you would need to test teratoma and see if these iPSC can generate teratoma. And so if they are going to be used in human or in vivo system, then that needs to be tested. And if it's going to be like extensive and like a malignant causing malignancy or so on, then there would be no go for that. But there are tests such as teratoma tests for iPSC models drive cells. Yeah.
I have another question to ask you. Also, besides the genetic modification, there was a group from China who present some data that they can actually chemically induce stem cells from somatic cells. Is this something, have you heard about that? Without genetic modification, just with chemicals in the dish?
No, I'm not aware of such a study, but yeah, so I don't have any comment for that.
But I can, I can find that the name of the university in China is doing that. If other people want to ask questions, go ahead. I will tell you about that.
Actually, I was in the presentation of that Chinese scientist in Pisa during the IPTA meeting, International Pancreas and Islet and Pancreas Transplantation. And also there is some activity in Netherlands. And they talked about it. As you said, there has been 3 or 4 patients so far they have treated. There is no long-term result. And people were interested to see how much it costs. They were very reluctant to answer that one, but people cornered them finally to answer it. And the cost that they have used for each patient so far have been $700,000 per patient. And you know that how the pancreas transplant works. And at this time, so it's just will be experimental. It will not be on a clinical basis until they make sure that it works for everybody. Their selection criteria was very strict, and they announced that was that as a keynote speaker in Pisa. I think you have heard also, maybe he invited him to WTC, World Transplant Congress there. So he's becoming bigger and bigger, but is far from reality of the clinical transplantation.
Yeah, his name is Professor Deng.
Yes, yes.
Professor
Yeah.
Deng, and he
Yeah,
actually
yeah.
present, two patients more
Yes.
than 2 years out.
Yes, yeah, and one from Netherlands. So altogether was 2 or 3. But you know that this type of work should be replicated by other centers to make sure that they are valid. Because sometimes you know that more than me, that the tricks that can happen in the research, and research should be ethically controlled, and make sure that several centers, they can replicate that one before it becomes reality.
Yeah, there are a lot of regulations, especially when it comes to stem cells, and especially FDA is very restricted. There are other countries that they have less restrictions, but mostly FDA and European regulatories are restricted, and also Japanese FDA as well. So I'm not sure about the Japanese regulation, Chinese regulations there.
Thank
It's
you.
not that much. In China, there is not so much of regulation, so we have to just see.
Yeah.
Thank you. I have Dr. Ehsani with raised hand and 2 questions from Dr. Bagheri that she has sent as a text message. I will read it later. Dr. Ehsani, go ahead, please.
Thank you so much for your presentation. My question is, whenever you want to get these kind of iPSCs, you kind of reprogram the adult cells. That's my understanding. Something like fibroblast, and then you reset kind of their epigenetic age. And for a model like Alzheimer's disease, this is an age-related disease. How do you think that we can kind of overcome that challenge?
Yeah, so as I said, the studies are still ongoing for the Alzheimer's disease. So we use the iPSCs to model the patient disease and find out the phenotypes. And then once we find out the phenotypes, we can use those phenotypes for the drug discoveries. And they can be also used for gene editing once you find out which mutation is causing those. And so it's age related. I don't know if I answered your question in a way that you were expecting it.
Yeah, kind of. My kind of challenge is that the comparison between these kind of iPSC that we can produce is going to be hard for Alzheimer's model. The rest of the models, you can use it, but for Alzheimer's specifically, I don't know if you faced that challenge or not when you were working with it, but that was just my question. Thank you so much.
Of course. Yeah, I haven't used Alzheimer's disease directly when I was in the lab at the time, but I was working on more genetic diseases. But definitely those phenotypes that you see in the AD patients are the ones that are trying to be improved. And once you can improve those phenotypes in terms of tau aggregations or other protein aggregations in the Alzheimer's disease, then definitely you can start recovering the patients or improve their life and their memories.
Thank you. I have a question from Dr. Nadia Bagheri on chat, and she is asking, Dr. Bagheri, if you are, you can ask yourself, or shall I read it from your chat question? Okay, I will read from chat. What is the best method to produce iPSCs in research and disease model? What about for clinical use? Do we do genetic tests such as NGS on iPSC cell to check genetic instability after passages? That was the question. Or 2 questions, I think.
Yeah, the first question. So the iPSC generation is through the 4 main factors that Yamanaka and Takahashi developed in 2006, and those are OCT4, SOX2, KIF4, and MIC-C. So those are the 4 factors that they are being used for generating iPSCs. And then
the second question was, do we do genetic testing such as NGS on iPSC cell to check genetic instability after passages?
Yes, we do. So we have genetic testing and sequencing for iPSCs after the passages that we want to start modeling them. So there are a couple of tests as a teratoma genetic test and staining to see the morphology is correct. Yeah, genetic is one of the tests that is required for.
Thank you very much for a very interesting and hot topic. It seems that because of so many questions and interest, thank you so much for bringing them up. And now we are ready for Dr. Maliha Mohammadzadeh. She is ready. Dr. Saidi and Dr. Matin, please go back to Dr. Mohammadpur's presentation. Thank you.
I really apologize for the background noise. I'm in another meeting. Can you hear me well, or is there a lot of noise?
Yes, we can hear you. Please go ahead.
Okay, thank you so much for this opportunity. My name is Maliha Mohammadpur. I'm a neuro-oncologist at Hakim University, and I apologize if I have to kind of run to another meeting. So, and just want to have a moment of solidarity with Iranian people. I was actually happened to be at the kind of celebration of Mahsa Jina Amini. All right, so going back to medicine. Here I'm trying to present kind of some go over primary CNS lymphoma, the epidemiology, how we treat and how we manage this kind of patients. Usually, primary CNS lymphoma are not being taken care of by neuro-oncologists. There are few neuro-oncologists who are interested, and I happen that I was interested. I had exposure and dealing with this kind of patients. So the epidemiology, usually the annual incidence is 0.4 per 100,000. Incidence increases as the patients are older than 70 years old. So it's usually 4 per 100,000 individuals. Most of the patients, this accounts for 1 to 2% of all non-Hodgkin lymphoma and 3 to 4% of brain tumor, primary brain tumors, basically. You okay? You hear me okay?
Yes, we are okay with you, but I think that you have a kind of background music that your voice gets echoed just a little bit.
Yes, there's so much going on. I apologize for that. I can't find
Okay, it's better now. It's better now.
Okay, perfect. All right, so next slide, please. So patients with primary CNS lymphoma, they usually present with multiple pulmonological deficit, cognitive behavior changes, and signs of increased intracranial pressure. 20% of patients with primary CNS lymphoma present with visual abnormalities, including floaters. They usually don't have B symptoms. It's very rare. And if we face or encounter any patient with B symptoms, then that would be a sign of secondary CNS lymphoma. We look for that. Clinical variants. Again, primary vitreoretinal lymphoma, they account for 60 to 80% of patients ultimately develop CNS. Very cautious about this patient. We kind of follow those patients, send them for ophthalmology evaluation. Intravascular B-cell lymphoma can also present in CNS. Next slide, please. For diagnosis and staging, it's very important to obtain brain MRI and total spine imaging. Usually we see multiple homogeneously enhancing lesions that are usually preventricular, deep brain, and they can happen in deep brain and corpus callosum. biopsy is a gold standard. We usually say no meet, no treat. So we usually try to say all clinicians who first-hand encounter this kind of patients to avoid steroid before biopsy, because the steroid can make the result inconclusive and makes us confused, and we have to chase to the corridors to find out what's going on with the patient. We send CSF, cytology, flow cytometry, molecular markers, and again, we check patients with physiological examination. We also do the CAT scan, the CT chest, abdomen, pelvis with ultrasound, visible ultrasound. However, if we don't find anything, usually do the PET scan on this kind of patients. And bone marrow biopsy when we think that this patient might have secondary CNS. Next slide, please. So the pathology, the most common pathology is the DLBCL, 90%. Most primary CNS lymphoma, again, they have diffuse large B-cell lymphoma, predominantly. Histology, they have a strong expression of CD20. We send most patients for next generation sequencing, genetic markers that so far has been found to be pathognomic for primary CNS lymphoma or MYD88 and CD79 mutation. And this has been becoming recently targeted therapy for this kind of patients. And also immune checkpoint inhibitors, because this tumors 30% show PD-L1 expression. Again, these are all the different corridors for targeting or immunotherapy for this disease. Please, next slide. Thank you so much. And then for prognosis, we usually use multiple scores. There is a MSK CC model. Usually focuses on the patient's age and their functional abilities or performance status. If the patient is younger than 50, they usually have an overall median survival of 8 to 8 years. If they're older than 50, depends on the performance status, the overall survival might change from 1 year to 3 years. If the performance is better, it's going to be 3 years, and if performance is not, then it's usually 1 year overall survival for patients over age 50. There's another registration method that they usually remind people use that. It's called International External Lymphoma Study Group, that they focus on patients' age, ECOG. Again, this is another way of European way of performance status, elevated serum IDH and elevated serum protein, CSF protein, and involvement of the brain lesions, preventricular, basoganglia, brainstem, and cerebellum. And depends on that, they define if the patient based on. Next slide, please. Okay. And the treatment of the newly diagnosed patients with primary CNS lymphoma has had a history, basically. Over time, many things has evolved, and in this regard, methotrexate was found, high-dose methotrexate was found to be the best backbone for chemotherapy. Common regimens, again, they include high-dose methotrexate with multiple variations, including rituximab, cytarabine. The MSK, we usually use RMVP regimen, rituximab, methotrexate, vincristine, and procarbazine. This is being called induction therapy. And then there is a consolidation phase when we try to make sure that this doesn't come back, and usually reduce dose whole brain radiation, bone marrow transplant, cytarabine, depends on the patient's age and their ability to manage the toxicity. Unfortunately, when you work independently in rural areas or central areas outside of the cancer centers, we face patients being treated with a steroid. and then the tumor or the lesion enhancing disease goes away, and the patient just get lost. I've had some multiple patients who've been treated by people, and they just, after a few months, getting steroid, come back to us, and the disease is really, at that time, we needed to get a biopsy, and it had a lymphoma and had to be treated. So that's why we usually tell people to start referring patients to oncologists, neuro-oncologists, to make sure we're not misdiagnosing this kind of patients with clippers, different, demyelinating disease or things without having a biopsy or extensive CSF studies that we usually send cytology, flow cytometry for lymphoma. In this case, flow cytometry is very important. Next generation sequencing is very important. Again, as I said, multiple mutations that can help us with diagnosis. Next slide, please. Sorry, the trajectory I corrected, but I forgot. I didn't get a chance to send to the right slide. Trajectory of the treatment in lymphoma, primary CNS lymphoma, as you can see, it's been a long way from 1970s to 2020 that started with whole brain radiation, because we used to give a steroid and whole brain radiation to all patients, inclusive with, without any exclusivity. And then in 1976, they started having intrathecal methotrexate. 1980s, they started treating these patients with a secondary CNS lymphoma regimen and CHOP. And then eventually in 1990s, the high-dose methotrexate started to evolve as the backbone chemotherapy for these patients. Multiple trials started to emerge around 2000 when they started to compare whole brain radiation versus whole brain radiation and CHOP chemotherapy or bone marrow transplant. Around like 2000, 2010, there were multiple trials really thinking about induction and consolidation as two different way of treatment, starting the regimen of treatment. In induction phase, we start giving the patient high-dose methotrexate, followed by either whole brain radiation, cytarabine, and they compare multiple regimen. Although most of the induction regimens have not been head-to-head compared, but at least for consolidation, there are some studies that have been comparing whole brain radiation with bone marrow transplant. Next slide, please. I just want to shine light on this part that, given especially to the surgeons, neurosurgeons, that they think, because since we request them to kind of do the gross total resection for most of the patients, especially for glioma patients, here it does not apply. Gross total resection did not show any improvement in overall survival or progression-free survival in primary CNS lymphoma. However, decompression subtotal resection has shown a slightly better, at least progression-free survival. So when I discuss with my neurosurgeons in our institution, we usually tell them if there is a chance or there is a high likelihood of progression, primary CNS lymphoma, we do not recommend gross total resection, because most of these patients, after getting chemotherapy, they tend to have a recovery of their neurological deficit. So by gross total resection, there is a chance that we kind of take that opportunity from the patient to recover fully. Next slide, please. Whole brain radiation, again, has been studied and compared as induction therapy in patients with complete response versus non-complete response. It did not show to improve much of the overall survival in patients with primary CNS lymphoma. However, it showed a good impact on progression-free survival. And then next slide, I think I'm comparing different regimens, yes. As I mentioned before, over time, there have been different regimens for induction. Dr. Lisa DeAngelos, she did the MVP, whole brain radiation and IT methotrexate with overall response rate of 94% and 2-year progression-free survival of 50%. over time, there are different regimens was evolved, and one of them, Dr. Muro, RMVP, followed by consolidation with bone marrow transplant, which showed overall the highest overall survival rate and 2-year progression-free survival. Although this has not been head-to-head compared, these are all single studies that have shown this overall response rate. Next slide. Validation, again, with patients who receive only induction versus those patients who receive consolidation. Those patients without receiving consolidation did not have as good as overall survival. So therefore, we do strongly recommend a way of consolidation for these kind of patients, either giving them cytarabine or high-dose non-myeloablative high-dose chemotherapy, or considering whole brain radiation for these patients, or again, stem cell transplant. Although there are some novel targeted agents that recently been included in different clinical trials and have shown a good maintenance, have been known as a good maintenance therapy for this kind of patients, but have been preserved for the time of recurrence or in case of relapse patient, refractory patients. Next slide, please. So here, yes, here in this study, Dr. Ferrari compared the whole brain radiation versus stem cell transplant, and it shows that a 2-year progression-free survival was comparable. No statistically significant difference between the two arms. However, overall survival was much, again, it was good in both groups. The only challenge was that it was not lasting for whole brain radiation, because most patients developed neurotoxicity, and so therefore the overall survival was not as sustainable as stem cell transplant. Slide, please. Treatment of refractory and relapsed is, we have multiple options. As I mentioned before, as you can see, there are multiple other lists of medication that's been used. One of the targeted therapies that has been evolving, and there are multiple generation of that now not in the market, basically in trials. One is ibrutinib. It's a BTK inhibitor, which works on PCR pathway. And next slide, please. Yes, sorry, I think I'm done. But this is the thing. There's multiple trials. There are CAR T-cell trials that have been used for relapse and refractory, BTK inhibitor for relapse and refractory. And there are some trials working on immunotherapy for PCS lymphoma. There was a small clinical trial done that 5 out of 5 patients included in this trial, they showed the clinical and radiographic response to nivolumab. Sorry, I really prepared my slides short period of time. I wish to, if you have any questions, I'm happy to respond. And I apologize for the background noise.
Thank you very much, Dr. Mohammadpour. That was very interesting. And yes, thank you very much for coming to our meeting, despite you were also in another meeting. So thank you. If there are any questions or comments to Dr. Mohammadpour, please raise your hand or send us a chat, message through chat. Okay, it seems that there are no question at this moment.
Thank you so much.
Thank you very much, Dr. Mohammadpour, and have a good time over there. And now we are going to the next presentation. Dr. Saidi, go ahead, please.
Yeah, the last but the least, not the least presentation is by Dr. Navid Mohammadzadeh, who's a physiotherapist in London, UK, and he's going to talk about pre and post-operative physiotherapy rehabilitation, optimizing surgical outcomes.
درود به شما. خیلی خوشبختم. اجازه دارم اینو رکورد بکنم یا نه دوستان برای خودم؟
البته شما میتونید، ولی ما رکورد هم داریم، ولی شما میتونید رکورد کنید. مسئله نیست.
مرسی. Okay, نمیشه. Okay. Anyway, thank you very much for giving me this opportunity. I'm Navid Mohammadzadeh from London, being graduated from Amsterdam University in 2003, and then moved to London, did my master program, and been working for my practice since then. Now, I was going to talk specifically about one pre and post operation, specifically to one surgery, but after discussing with my colleagues, Dr. Hossein Shukhamiri, we decided to go for general pre and post operative physiotherapy rehabilitation. Basically, this is quite a broad subject, and I try my best to give you some just brief review about understanding of the importance of pre and post operative physiotherapy, strategies across different surgical specialties, and the clinical reasoning behind this, and how the patient center should be focused point, and also what kind of outcome measurement tools we use, and what are the future directions. Now, structured physiotherapy prepares patients for surgery and restore functional independency, and reduce complication, enhance mobility, and improve quality of life. Applies across all different types of surgery, including orthopedic, neurological, cardiopulmonary, and internal organ surgeries. I'd like to add that in most of the cases, unfortunately, the pre-operative physiotherapy somehow have not been emphasized by many surgeons and consultants. And in reality, we see so many benefits, and the goals of preoperative physiotherapy include, not limited to, strengthening of the muscle group which is going to be involved in improving patients' balance, mobility, and cardiorespiratory fitness. The intervention which we apply include muscle strengthening, aerobic activity and conditioning, respiratory physiotherapy, which is so important, functional task, and also patient education. As you probably most of you know, that in physiotherapy we have quite good enough time to spend with most of patients, and therefore patient education for different surgery and different procedure would be really important during this preparation phase. Now, regarding post-operative physiotherapy, there is so much to be done, and the goals of post-operative physiotherapy include early mobilization, getting back on patients on their feet, and also achieving functional recovery, and educating and allowing them to do their daily activity in a safe way. The intervention that we use are early mobilization again, range of motion, and muscle strength, and also gait and balance training, which are so crucial, ADL integration, pain and other complication, which all will be managed during post-operative rehab program. Now, I will go through a couple of important surgical procedures. The first one is orthopedic, which we use some muscle strengthening and functional tasks, as mentioned earlier, and the post-operative include early mobilization, improving range of motion, strength, functional ADL, and gait. And as you might have seen, in post-operative is quite well known amongst all specialties, but when it comes to reality, I want to give you a couple of examples that the fear of movement, for instance, is one of the main focus points. I have right now one patient which has had very simple arthroscopy on his knee due to a small fragment in his knee joint. And although physically he's very fit, he does all his activity, we even practice some kind of sport activity, but still he's has to be pushed to step on and off a small box. Now, this fear of movement is something which most of people go through during post-operative rehab, and our physio colleagues do apply really lots of attention and do a good job for that part. In neurological surgery, again, there is so much to be done for preoperative. We focus on functional mobility, balance, respiratory, and again, psychological preparation play important role. And in postoperative, early mobilization is so crucial for those group of people who's gone through neurological surgery. Neuromuscular retraining and re-education is another crucial phase, which especially with some neurological and also orthopedical surgery. For instance, when you have total knee, then the neuromuscular role or proprioceptive training would be so crucial. And the same would be for balance and gait, because patient try to move further and lift one of his foot, but struggle to land on the other side. So there's lots of really details, things which goes on, and as a physio, you really need to focus on this. For instance, someone has had lumbar decompression, how soon and how good he could gain independence in walking. Then cardiovascular and pulmonary surgery is somehow have given good attention during hospital period, but once they've been discharged, again, most of people are not aware of a good effective of physio rehab. Again, for pre-op, we do focus on aerobic conditioning, respiratory exercise, including even breathing technique and functional training, and also certain technique such as puffing, huffing, coughing, all to deal with mucus. And as a post-operative patient also, we will deal with early mobilization, getting them back to walking, to simple daily activity, and also lots of respiratory exercise. Now, when it's come to this kind of respiratory exercise, especially for cardiovascular, but I would say actually is valid for all surgery, the intensity of this loading and exercising is so crucial. How much you ask this patient to walk in the 3rd days, how much he can manage that, how tough sometimes is for a patient. One of the colleague was talking about obesity and BMA. So how tough is for someone just get off his bed? That kind of thing in reality is quite challenging and need really good attention. Or someone with, let's say, coronary artery bypass grafting, the fear of movement. Am I able to walk? Am I able to stand? Even using walker and crutches sometimes is so challenging for them. And there is where the clinical reasoning comes on, that we can educate patients, give them enough reason, and tell them about recent literature and guidelines, that you can reassure them you'll be safe. And of course, always considering the surgery procedures and protocol of the surgery itself. And then we get to internal organ. Sorry, I am rushing. I know it's the last one and everyone is tired. This is a subject which been almost not emphasized again with most of surgeon which I see in my daily practice, because it's okay, just a kidney transplant. But actually, because the internal organs are located in abdominal area, and the abdominal or lumbar region is the core of the body and core of center of gravity, that means everything they do, either rolling in their bed or sitting or standing or lying on their bed, require lots of movement and function from the core. Therefore, physio play an important role getting them back in their feet and making them mobile. Therefore, core strengthening is so crucial as a pre-op. And the same for post-op core stability would be crucial because most of the time the surgical stitches are almost 10, 15 centimeter. And then again, cardiorespiratory conditioning, both pre and post. And again, getting them back to ideal activity, and also home adaptation. Most of these people will struggle to climb their stairs to go to their bedroom. For weeks, they sleep in sofa in the living room. We've seen them. Unfortunately, most of surgeon colleagues, they don't face this kind of situation after operation. They've done the job well done, but we as a physio deal with this on day to day, and sometimes not being able to move, it causes so many other complications. For instance, a liver resection patient regained independence in 6 weeks with a good rehab program. And the clinical reasoning, which is so important in physio, we focus mostly on individual assessment and SMART goals, integration of home environment and lifestyle functional tasks, and most importantly, the current guidelines and the special or a specific protocol for each surgical procedure, which being given to physio mostly by surgeons and consultant. Now, there are ways that we measured this outcome, and there are lots of outcome measurement tools, including measuring the range of motion, strength of the muscle, time up and go, PSFS, patient-specific functional test, scale, visual annual scale, and cardiorespiratory measure, six minutes walk, balance. All of this will be measured on a weekly basis and evaluated nicely. And also, we report this outcome, we discuss with the patient, especially the pain and functional status is so important, which all of this help them to get back to a good quality of life. And guiding rehabilitation progression and goals achievement is the follow-up step. Now, the challenges in physiotherapy, as I mentioned, a couple of them throughout my speech, there are so many. As I said, fear of movement is one of them. Patient adherence, unfortunately, many Middle East and Iranian do not care about this kind of thing as much as they're supposed to. And comorbidity is another issues which we deal with, so many complications, especially in hospital. Our colleagues are facing with so many complications. And of course, motivation, and someone like just go get back to football, the other one doesn't really care. And healthcare system limitation, there are so many in many countries, we have still so many limitations. Variability in rehabilitation program, which again, we refer to different physios, different approach, different management skill. And post-discharge rehab, that many people end up with living alone or living with 3-floor stairs, and there they stick with not being able to climb, or just getting to the corner shop buying a newspaper for so many senior people. Now, the strategy and direction for future are mostly should be aimed on patient education and engagement, multidisciplinary collaboration, which is within hospital setting are quite good. But again, once someone been discharged from hospital, there are no such things at all. Occasionally some communication via emails and letters, but I don't think these are enough. Standard protocols, which are existing for most of procedures, and for instance, cross ligament or total knee, you name it, post cardio, but still there are so many standards protocols should be set up and applied. And telerehabilitation and technology is another focus point for the future, and also, of course, personalized rehabilitation and outcome-based monitoring. Now, as I mentioned, physiotherapy bridges surgical intervention and functional recovery. Most of people, unfortunately, don't end up with a good rehab post-surgery. And I've seen a patient with heart surgery back home in Iran. It was 6-7 months post-heart surgery, and I asked, he was sitting somewhere, I asked, how much do you walk? When after a few minutes chat, He said, I just get from my home to here. It was a kind of bench. He was sitting nearby a street. I said, how far is it? He said, 2 minutes. And I said, now 6 months, you're still walking 2 minutes? He said, yes. When I asked him why you don't walk further, you don't build up, he said, I didn't know. I just thought I can walk this 2 minutes, that's all. So there are so many dilemma, unfortunately, and challenges, and therefore, this kind of approaches I would think would be very helpful. And mobility, strength, endurance, and making someone independence is really important factor post-operation, and clinical reasoning and focusing on patient and their objective is also important matter. There are lots of paper and articles. This was a really good review, in my opinion, and made me to write 5,000 paper about this matter, which is published in my website, in case anyone is interested. Thank you very much for this opportunity. I'm happy to answer any question if you guys have it.
Thank you very much, Dr. Mohammadzadeh, for a very interesting.
Sorry, I'm not a doctor. I'm just, I don't have the title of doctor. Thank you.
Thank you very much.
I got master's degree. Thank you.
Thank you very much for your presentation. It seems that we have two hands on, Dr. Amiri first and Dr. Saidi next. And if there are more questions and comments, please raise your hand or send us a message through chat. Thank you. Dr. Amiri, go ahead.
Thank you so much, John, for this wonderful talk. I think it's almost a forgotten item in the at least American was a health system, which is very important. As you said, if you prepare the patient preoperatively, the end result may be better with less days of hospitalization, which will be also economically to the advantage of the country. So I think it's a time to run a study comparing in a randomized study those people who receive preoperative physiotherapy to those who do not, and follow them postoperatively, which I think will be in favor of preoperative physiotherapy. And that I think will be something that we can encourage our residents to start on this project. I think it was a very good talk. Thank you so much.
Thank you very much. I'd just like to add one point, Dr. Shkamil. First of all, thank you for giving me this opportunity. You know, when there was 2 years, I believe, ago, one study that they initially, when there was a cast on fracture forearm, they were thinking is due to fracture, which is cause atrophy. But this study have proven that within 2 weeks of casting a healthy forearm, we have 40% atrophy. Now, imagine someone with liver transplant stay in a few weeks in hospital. How much we are dealing just with the atrophy factor. Therefore, strengthening these people or conditioning or with a different objective, it helps so much for post-operative. Thank you. I'm happy to participate in this kind of matter.
Dr. Saidi, befirmayid.
Yeah, thank you. That was very good topic, and is there's a very huge debate about that. Especially for our patient before transplant, we check that frailty score, see how fit they are, and if they are not, we send them for physical therapy. And also after any kind of surgery, now I think most academic medical centers in the U.S. adopt this protocol called ERAS, early recovery after surgery, which have different component to it. One of it is just early mobilization, physical therapy, and shown that by implementing those protocols, you can actually decrease the length of stay and decrease the cost. And that eventually needs to better have green hospitals. It's important you all understand that, hospitals is one of the major cause of air pollution and, damaging the environment. I'm shown that by early recovery and early discharge from the hospital, basically you can decrease air pollution and also have a positive impact on the environment. That's why these, I think, protocols are very important.
And finance. Finance is a huge matter for hospital if they can. And another point is, Dr. Saidi, is before, you all know, is when they were doing total knee or total hip, they were letting patients start working after a couple of days or weeks sometimes. Now, because of all these studies, they let them work straight away next day, and within 2 days they discharge them. So that's a good example of how huge differences would be. Thank you.
Dr. Amiri?
I should mention, Dr. Saidi raised the issue of ERAS, that actually ERAS was started in Denmark by my chief resident and my friend, Dr. Henry Killet, that started the whole idea of ERAS and now become world renowned. To come to different places to talk about that one. He did not mention so much about what Nabijan is saying, that at least we may need 2-3 days of physiotherapy also. He was a little bit less and also starting right after surgery, but that was the initiation. I think we should implement what Nabijan is saying about considering this physiotherapy before surgery. It will help a lot, both in the hospital and post-operatively as a whole.
One quick comment, Dr. Shukamiri. If you guys are, I'm sure, familiar with NICE guideline, National Health and Care Institute in the UK, in all of these guidelines, pre and post-operative physiotherapy have been really highlighted. I am not familiar with many other countries, but with the UK is quite familiar. But still, most of people are not even aware of pre-operative physio rehab.
Post-operatively is now a must, but pre-operatively is important
Yeah,
also.
exactly.
Thank you very much. If there are any more questions or comments to Mr. Mohammed Zadeh. Very good.
I should mention that he's our good friend. We are working in together, me, Dr. Saidi, and him in the what's that? سازمان ملی رازی, that we are working together.
Very good.
Everyone welcome to join us.
مرسی.
Yeah.
خب به نظر مرسی. به نظر میرسه که ما we are at the end of our session today. Thank you very much to all participants, and we hope that we can resume our second day of conference tomorrow at 12 o'clock p.m. Eastern Time. 12 o'clock tomorrow Eastern Time, Sunday, and we hope to see all of you again and many more. If there are not any more questions or comments, so we can end the session.
Yeah, I would like to thank everyone. I think this was a great session, very interactive and interesting presentation, and I hope to see everyone tomorrow.
You should be impressed by how talented our young generation are. I'm really proud sitting here, feeling so much proud to see all of our young generation. Thank you so much for all of you.
Thank you.
See you all tomorrow.
Thank you all for the opportunity. Thank you so much.
Thank you very much.
And have a good afternoon. Bye-bye.
Thanks to Shukur Amiri family.
Thank you.
I see a few names there. Thank you.
It's not all. Some of them are in England with you.
Okay.